Hi guys, let's begin with the next part, and that is parasitology. You know a couple of chapters which are always troublesome when it comes to this particular topic. I'll make sure that I can simplify it in some manner for you. We've got a lot of mnemonics that are coming up your way, and I hope with the help of that you're able to easily memorize it. Some funny, interesting stories also on the way we'll be doing. So I hope all in all the experience is something that can help you recall and retain this information, because it's definitely volatile. Let's get going. So first I want to give you a very brief, let me tell you, you don't have to learn this classification. I'm only giving this 1.5 minute classification so that you get to know that, okay, these are all the topics and these are all the parts of this particular section that we are going to do. So first and foremost, I'm going to talk about all the different amoeba. And under amoeba, I will be dividing them into the ones that are going to come up in the intestine and the ones which are free living. So which is something we'll be getting from swimming, from pools and ponds. So basically the free living amoeba that are there. So giving you a brief outline, under the intestinal amoeba, I'll be talking about the very famous Entamoeba histolytica, and we will also be talking about Entamoeba coli. Under free living, I'll be talking about Naegleria fowleri. This is something which gets you a lot of questions, Naegleria fowleri, and its cousin brother, that is Acanthamoeba. So both of them belong to the same family. Now there's another intestinal one, but that is a ciliated organism. The only ciliated organism that we are going to refer to in this particular chapter is going to be Belantidium coli. So I'll be talking about it, and a very interesting story coming up your way for Belantidium. The next we have in order are going to be the flagellates, the ones which are motile, which have a flagella in them. So they are going to again be as per the site. If you say that it's going and sitting in the intestine, or if it's something or having a habitat in the genital region. So remember, in the intestine we have the very famous Giardia lamblia. We all know Giardia lamblia goes in the duodenum, so it is Giardia lamblia. And Trichomonas vaginalis, the name only tells me, Trichomonas vaginalis tells me that it's of course going to be a genital protozoa that we have. Similarly, we have something that is going to be present in the blood and the tissues. Which are the flagellates which are present in the blood and the tissues? They are going to include Leishmania and Trypanosoma. Leishmania and Trypanosoma, and under Trypanosoma, so many of them I'll talk about, Trypanosoma cruzi, brucei, we'll come to that eventually. After that, we have the next family to do, which we call as the Sporozoa. Now, when I'm talking about the Sporozoa, I know all of you only focus on the very famous Plasmodium malariae and Malaria kissa. There's another one called Babesia that you focus on. But what you usually tend to miss out on is that even Toxoplasma and the different other coccidian parasites, all of these are basically coccidian parasites. These are also the ones that are coming under Sporozoa. They also belong to this particular family. Toxoplasmosis and coccidian parasites is a family that comes up over here. So this is going to be the beginning, or you can say almost half of your section of parasitology. The next half of your section, I'll give you a brief in a while. Once we finish with all of these, we'll go to the cystodes, the trematodes and the nematodes, right? So first, let me start off with this section of parasitology, and I'm starting first with the amoeba. Under amoeba, I'm picking up the intestinal amoeba, which means I'm primarily going to talk about Entamoeba histolytica. So let me tell you that no matter what I talk about in these sections, I will always be referring to trophozoite and cyst. And where I won't have these two forms, I'll let you know. But for all practical purposes, everywhere there's going to be a trophozoite and everywhere there's a cyst. Over here, you have a preliminary category also known as a pre-cyst. So we have trophozoite and we have cyst over here, right? Okay, these are the three stages, out of which you need to know that the infective stage that we are dealing with, is the cyst form. So I can now tell you all the details. What are we going to eat and consume? It's going to be the cyst form. So have a look at this, guys. First, if I ask you, who is the host? Of course, we are the hosts that we have. Humans are the host. I'm going to show you a life cycle shortly, so you should be able to identify. What did I tell you is the infective form? The infective form is the quadrinucleated cyst. So basically, I'll have a cyst, and that cyst is going to have a total of 4 nuclei. That cyst is going to have a total of 4 nuclei. So quadrinucleated cyst is going to be there. What is the infective dose? How much of that cyst should we be consuming? Less than 100 cysts are also infective. You'll say that is a very small infective dose that you're talking about. So before I proceed, I actually want to in the beginning only make a list for all of you, which are all the things which are going to have a small infectivity dose. Everything in parasitology or in general in Microbiology, which is going to have a small ID. ID refers to infectivity dose, means little bit of that organism is also going to cause infection is us. So how am I going to learn this? So we'll say, ma'am, everywhere in micro we need a mnemonic, na? So we are going to go ahead with a mnemonic. Small means what? Small means chota. So I've made a mnemonic chota small. There's a mnemonic that is chota small that tells me that first and foremost, C for Cryptosporidium. I'll be teaching you this in a while. Cryptosporidium, we need very few organisms to be able to cause infection. Then over here, which entamoeba? Entamoeba coli or entamoeba histolytica? So as I'm saying over here, it is H for entamoeba histolytica, which requires a small infectivity dose. Similarly, if I ask you go back bacteriology and tell me which E. coli can cause entero, H wala, enterohemorrhagic E. coli. Enterohemorrhagic E. coli. Okay, let's move forward. Next, we have something known as S pe aate hai, S for Shigella. And if I use this word in the opposite direction, lamb, it is sounding like lamblia. So now the next organism is going to be Giardia lamblia. So please note, these are all the organisms which are going to require a small infectivity dose. Quick recap: C for Cryptosporidium, H for entamoeba histolytica, H for enterohemorrhagic E. coli, S is going to be for Shigella, and the entire lamb is going to stand for lamblia. These are all the ones with a small infectivity dose. Sorted for us. So now when we come back, yes, entamoeba histolytica was a part of that mnemonic. So it's a small infectivity dose. Also, these cysts can easily survive chlorination of water. This also list I'll make in the end once we study everything, na, that which are the cysts which can survive chlorination of water. So that makes it all the more dangerous because it can survive the chlorination. Now finally comes the life cycle. How am I gonna get this particular infection? So please note, the mode of infection is most commonly, ye PYQ hai, what is the most common mode of infection? It is feco-oral, and very rarely is it homosexual, but the most common that will be asked means through contaminated food and water we are gonna eat it up. So it's time that I look at the life cycle finally. Now, one advice to all of you, which is a very common mistake that all of you do, you feel that I have to go and study every word of the life cycle, every detail of the life cycle, only then I'll be able to crack it in the exam. No, if you know that trick of catching a life cycle, then I think you can easily ace the exam. You don't have to know every nitty-gritty and every sentence of a life cycle. So first and foremost, make it a habit from today onwards. Whenever you look at a life cycle, your first thing is pick up the host. Because abhi to for the first part of parasitology, I will only show you human all the way. But later on, I'll show you animals. I'll show you certain bugs. So by looking at those animals, if you know it's human and a fish, you know, okay, these are the two organisms this life cycle can be. If it's human and a pig, these are the two organisms it can be. So the host is going to make you win half the battle. So first over here, I'm only dealing with the human and something that is happening in the environment, right? After that, I can see one picture over here, and that picture, if I zoom in, I can see 1, 2, 3, 4. I can see 4 nuclei. Quadrinucleated cyst gives me the first hint that this is a case of entamoeba, because I had just now studied that for entamoeba histolytica, we have the very famous quadrinucleated cyst. So yes, one hint I'm getting is entamoeba histolytica hai, and what is happening? Ingestion. Ingestion basically means that this is a feco-oral route. It is contaminated food and water through which I am getting it. And how much of dose? Small infectivity dose, right? So the route and the infective form is clear. Now it's going to go inside my body and do what? So you'll say, ma'am, it has gone in as a cyst. Means there are only two forms. There's a cyst and there's a trophozoite. So if you have consumed the cyst, what will it make next? After cyst, it will make trophozoite. So I can say the cyst is gonna come out and make a trophozoite. There is going to be excistation that occurs in the small intestine, resulting in the formation of 8 trophozoites. Resulting in the formation of 8 trophozoites. Now you'll say, fine, a trophozoite ban gaya. Let's move again back into the same cycle. So now what is going to happen next? The next stage is make a cyst. Encystation. Encystation, N obviously means going in. So we are going into the cyst. First, we were exiting the cyst form. So when we were exiting the cyst form in the small intestine, we decided to make trophozoites. Now we are entering the cyst form. So now this means that these 8 trophozoites in the large intestine are going to again make a cyst. So there's first exit the cyst, then enter the cyst. And what I can see over here is that both these forms are coming out in the feces. So this means that when microbiologist is looking at the slide, microbiologist can see the cyst form also and the trophozoite form also. I need to know how they look like. So I will tell you in a while how they are going to appear, but I can see both of them. So ultimately tell me, this is what has been passed in the feces. What has been passed in the feces can be both trophozoite and cyst. After that, whatever is going to happen in the environment. Now, there's no other host. Whatever shall happen will happen in the environment. Hai na? So now tell me that environment mein who survives? Who is the more stronger one always? Cyst is always stronger. So I can say that the cyst is going to survive in the environment. The cyst survives in the environment. Till now, I hope the basic is clear. We consumed the cyst, right? But we can take out everything, cyst and trophozoite. First, the cyst entered our body. Cyst decided that I'm going to make trophozoite. So time to exit from the cyst is excistation. After trophozoite, again when you had to enter into the cyst stage, that is known as encystation. So this is the life cycle that is done. But there is one concern that we have. Gradually I'm going to go into the details of this life cycle. If they ask you that how did it so nicely come and attack, what are its virulence factors? So first and foremost, it has an antigen. There is known as Gal-Galnac antigen. There is something referred to as Gal-Galnac lectin antigen. Very, very important. So later on, when I'll tell you for the diagnosis of Entamoeba histolytica, we have to do antigen testing. I'm doing the Gal-Galnac antigen testing. Other than that, there are enzymes. There are certain metalloproteinases and neuraminidases. So remember, metalloproteinases or metallocollagenases means the same. And proteinases, matlab, they are going to break the collagen, the protein, and neuraminidase. These are the enzymes. So I will actually tell you in a while how these enzymes and this antigen is so important for Entamoeba histolytica. We have a lot of other entamoebas, na? So this is what we have to differentiate it with. So this antigen and these enzymes will help us very soon. So virulence factors I've understood. Now let's understand what is it actually going to do. So what was the organ that I was telling you it was going into? It was going into the intestine. Guys, it's one of the causes of traveler's diarrhea. It goes into the intestine. It causes traveler's diarrhea. But if I ask you what exactly is going to be caused in the intestine, you have a very famous ulcer, and that is known as the flask-shaped ulcer. This is known as the flask-shaped ulcer. Now let me tell you that every student tends to ask me that why flask-shaped? If it was an ulcer, it could have gone through and through. It could have gone straight away like this through and through. But no, see, what is it doing? First, I'll tell you a pathogenesis behind it. It is going to go and damage which layer? It can damage the mucosa. So mucosa to damage ho gaya. After that, what comes after mucosa? After mucosa comes submucosa. It says, fine, I will damage the submucosa also, not a problem. But once it reaches the muscle layer, the muscularis is very, very tough. It cannot break the muscle layer. It's not that easy to break the muscle of our body. So it says this is broken, this is submucosa is also broken, but after that I can't break. So what do? Now I start breaking the submucosa on the left and the submucosa on the right. So now it started becoming like a flask. So initially it was breaking downward. Then it realized that I can't go further down. So let me start breaking on the sides. That is why the reason of the flask-shaped ulcer everyone's understood. It's not able to break the muscle layers. That becomes the base. That is a very famous point. Flask-shaped ulcer. You want to zoom into it. You say, what is there in the flask? What is all this dirty material that is there? Let's have a look at this dirty material, right? So please note, this dirty material are the organisms, trophozoites. So look at this next picture. Inside the flask, or if I can give you exactly where I'm talking about, inside the flask, you're going to see all these trophozoites. But can you see something interesting in them? You'll say trophozoite means there should be one nucleus, like every organism has one nucleus. So I can see the nucleus over here. This big dot is a nucleus. But other than that, I can see many red color tiny dots here and red color tiny dots here. This means these trophozoites have engulfed RBCs. These trophozoites have engulfed red blood cells. What is this process known as? This is known as because RBCs eating up phagocytosis. Erythrophagocytosis is what it is going to have. So please remember, the trophozoites are going to show the presence of erythrophagocytosis. Very important. So the intestinal part is sorted for you, but that is not how the patient is going to, this is what a pathologist or a microbiologist is seeing. How does the patient present? So in most of the cases, it is an asymptomatic condition. Let me tell you, in most of the cases, this is going to stay in the lumen and it is going to be totally asymptomatic. Over 50 to 80% of the cases can also be asymptomatic. So if someone asks you most common presentation, it is entamoeba is asymptomatic. But when it starts presenting, please remember, of course, that is known as amoebiasis or amoebic colitis. It affects the large intestine, it affects the appendix. And how is the patient going to come across with? The patient is going to come across with bloody diarrhea. The patient is going to come to you with bloody diarrhea. Complications socho after appendicitis, if it ruptures, can there be perforation? Can there be peritonitis? This is a complication of any intestinal disorder. That is also understood. What else can this patient have? In very, very chronic, long-term cases, in extremely long-term cases, chronic condition could socho. Look at the name, that will tell you. Amoeba, I know, entamoeba. Oma means tumor. Is there a tumor that has formed over here? No. Some area, some localized area, which they are calling as amoeboma or amoebic granuloma. You'll say, ma'am, so many misnomers. One way you're calling it oma, so is this a tumor? It's not a tumor. You're calling it amoebic granuloma. Is it like granuloma like TB and all? No, it is not. Please remember, these terms are being used only because they wish to describe to you granuloma kya hota hai. Go back to your pathology lectures. What is granuloma? Chronic inflammation. Na? So whenever they want to tell you that this condition has become very, very long standing, maybe you gave antibiotics, the antibiotic did not work. Maybe you gave some anti-helminthic drug, you gave some anti-parasitic drug. You really don't know what the disease is. So you gave some treatment which did not work on this condition. As a result of which this entered into a chronic condition, and that is why they've called it amoebic granuloma or an amoeboma. Where does this occur? This tends to occur in the rectosigmoid region. Okay, on that note, we are done with this basic thing. But now I want to tell you that other than the intestine, what else can be affected? The most common extra-intestinal feature is, of course, the involvement of the liver. So you can see over here that I've given you this brownish color pus. From where in the liver have I got it? Entamoeba histolytica involves the right lobe posterior superior surface, PSS. Remember, it affects the right lobe posterior superior surface. That is the part of the liver is affected. So if I put a syringe and I take out the fluid out of it, I'm going to get this very famous brown color anchovy sauce appearance. We get this anchovy sauce appearance, which is a brown color fluid. So anchovy sauce appearance gives this brown color, right? Now going back, if I look at this brown color breaking liver under the microscope, what am I going to see? I am again going to see trophozoites in the pus. So they ask you for the diagnosis of amoebic liver abscess, for the diagnosis of this condition, that is amoebic liver abscess, what is the diagnostic part that you're going to see under the microscope? And that is going to be the trophozoite. So simple. When it was the intestine and you had the flask-shaped ulcer, what were you seeing inside the flask? Trophozoites. When it's the liver and you're seeing the anchovy sauce appearance, what do you see under the microscope? Trophozoites. Everywhere it is trophozoites only. I hope everyone understood the overall mechanism of it. So now I can go ahead and I can actually tell you that it is going to intestine also. It is going to the liver also. But how exactly does it attach? This is an information I want to give specially for students targeting INI CET. There is something known as trogocytosis. What do I mean by trogocytosis? So can you see this is the human cell? Could be our intestine, it could be our liver, anywhere that it wants to go. And this is Entamoeba histolytica. So what is the antigen? What did I tell you? Entamoeba histolytica has what antigen? Did I say it has the gal-galnac lectin antigen? So here we have the gal-galnac lectin antigen, and this is some cell of our body. Intestine, liver, something. So you can actually realize that the attachment is occurring by this antigen. The antigen is attaching by, or the organism is attaching by the gal-galnac lectin antigen. And after that, what is trogocytosis? Trogocytosis is, you've seen a rat, how a rat nibbles. If you keep nibbling, dheere dheere, it will keep on destroying a place. This is basically going to be very chota, very minute killing, or if I can use the word nibbling, it is now gradually going to nibble the cells. Dheere dheere, it is like a burrow, like a rat creates a burrow. It is going to gradually, take out one layer, second layer, third layer, like that it is going to destroy. So this killing is known as trogocytosis. Please remember two things. Trogocytosis is seen with Entamoeba histolytica, and trogocytosis is something which is following by attachment of gal-galnac lectin antigen. On that note, now let's start off with the diagnostic part of Entamoeba histolytica. So what sample will you take? Of course, it's something that causes diarrhea, so I'll have to take stool sample. But why have I written 3 stool samples? Because this is not shed off in the diarrhea sample every day. This tends to take up intermittent shedding. This tends to show you intermittent shedding. This means you are going to take the stool samples on 3 consecutive days. If you see the cyst and trophozoite on first day, okay, then don't do 3 days. But if you don't see it on first day, then do a second day sample. Then next, if you still don't see it, do a third day sample. So you have to at least take 3 consecutive day samples out here. That's one thing. And what are the 2 forms that I'm telling you? You'll see trophozoites and you'll see cyst. Let me tell you, if you only see trophozoites, that means the disease is currently active. Like you were seeing trophozoite in the intestine ulcer, trophozoites in the liver. If you start seeing trophozoite in the stool also, this means the patient is currently having an active disease. If you only see C for C, if you only and only see cyst stage in the stool, that means it is a carrier stage. So now that I've told you everything, why don't we have a look at the trophozoite and the cyst that we have over here? So here you go, guys. This is a trophozoite and cyst of Amoeba histolytica. I label this as the trophozoite and this as the cyst, and I can very well see that the trophozoite number 1 has what pseudopodia? A pointed pseudopodia. Very, very important. Point number 1. I'm not, again, guys, in microbiology, the problem is that students end up reading so much of irrelevant information. This is concave, convex. That's not going to help you anywhere. What is going to help you are the key features. So the first thing, there is going to be a pointed pseudopodia. Next, I have to focus on the nucleus. When I look at the nucleus, how many number? What is the number of the nucleus? The nucleus is going to be single. So the nucleus is going to be 1. And if I draw the nucleus, I can draw the karyosome right in the center. The central dot. Can we all see that central dot? So this is known as a central karyosome. Very, very important. Central karyosome, and all the other chromatin is on the side. Is it looking like a wheel? Like the spokes of the wheel? So this is known as the cartwheel nucleus. This is the identification point over here. You'll see one nucleus. That nucleus is going to have a central dot and a cartwheel appearance. What else can I see? Did I just tell you that has a property of eating red blood cells also? Yes. So can I say this trophozoite is going to show me erythrophagocytosis? That also is something that everyone knows. So for the trophozoite, you learn 3 things. Point number 1, it is going to show you a pointed pseudopodia. Second, it is going to have a nucleus which is cartwheel in shape. And third, it's going to have erythrophagocytosis. Now let's come to the cyst. How many nuclei do you see in the cyst? I can see a quadrinucleated cyst. So basically, here the number has changed. The nuclei are between 1 to 4, but do you notice that their structure is the same? They look like the same cartwheel that I'm talking about, the same cartwheel that we have studied. So you realize that the structure shall remain the same, only the number has changed. So the trophozoite has 1 nucleus, the cyst has 1 to 4 nuclei. What else can you see over here? I can see a very, very thick body over here, which is known as the chromatoidal body. This is known as the chromatoid body or chromatoid bar, and they ask you the composition and the stain for this bar. Very, very, very important question that I'm going to tell you now. So this chromatoid bar is going to get you a lot of questions. So we'll make a separate table for it because I know I'm expecting both these questions in the future exams. They are PYQs also. So first and foremost, they ask you what is the composition of the chromatoid bar. So it is made up of RNP, that is ribonucleoprotein. It is made up of ribonucleoprotein. And second, they will ask you how can we stain the chromatoid bar? It is by a stain called iron hematoxylin. It is by a stain called iron hematoxylin. So repeating, it is going to be ribonucleoprotein wala question, so mug it up. RNP, RNP, RNP. 3 times I've told you, it is very, very important. That is what a chromatoid bar is made up of. So what did I say? Nuclei are 1 to 4. This means by division, first there will be 1 nuclei, then there will be 2 nuclei, then there will be 4 nuclei. So that is how it is going to mature in its future, right? This is about Amoeba histolytica. You've done this trophozoite, you've done the cyst. Before I go forward in my discussion of the rest of Amoeba histolytica, I want you to differentiate this Amoeba histolytica with a non-pathogenic intestinal amoeba, that is Entamoeba coli. E. coli is not Escherichia coli. It's not the bacteria wala Escherichia coli. E. coli that I'm talking about over here is the parasite that is Entamoeba coli. And try to compare. What was Entamoeba histolytica having? Dono ka trophozoites compare karo. That was having a pointed pseudopodia. What is this having? This is having a blunt pseudopodia. Entamoeba coli has a blunt pseudopodia. Next, if you look at the nucleus, number was 1 earlier also in Entamoeba coli also the nucleus is 1, but can you see the difference in the shape, the structure? Do you have a central karyosome over here? No, I can see an eccentric karyosome. The dot is somewhere at the periphery. So that is very important for you to know. This is going to have an eccentric karyosome. It doesn't have that cartwheel appearance that you have. Also, do you see any red blood cells being engulfed? The third point is also not there. Dekho, 3 points the, तीनों alag. That had a pointed pseudopodia, this has blood. That had red blood cells, this does not. That had a cartwheel nucleus, this does not. Simple. Now let's come to the cyst form. When I'm comparing the cyst form, how many nuclei could it have? It could have 1 to 4, but look at the nuclei in the cyst form over here. Over here it has 1 to 8, octanucleated. Over here the nuclei are going to be 1 to 8, and again it's not a cartwheel. Second, that had a chromatoidal bar, a very thick chromatoidal body. This has very thin filamentous chromatoidal bars. This has a very thin filamentous chromatoidal bars, right? Okay, now on that note, we are done with all of this. We are over with it. Now I can get back to my classification. So I told you that when you're doing the diagnosis, you will take 3 stool samples. You will look at trophozoite and cyst. You know how to identify them. What further? You will have to do a culture. When you're talking about anything to do with the parasitology, you will have to do a culture. Means I'm talking about something called a stool culture, and I have 2 types of media that can help me do it. Polyxenic media and axenic culture media. Many students don't know the meaning of this only. So please note, a poly matlab it has many things. It is going to be supplemented with bacteria. You will say, hang on ma'am, you want to do the diagnosis of a parasite and you are supplementing your culture media with a bacteria. Now, why has that happened? That has basically happened because maybe your parasitic load is very low. It is when there is a low parasite load. So if you have very less parasites, you are going to tell them that please take some food. I'm giving you bacteria in the form of food. Eat that food and grow. I will see you more in numbers. So now I'm going to tell you a very scary list in front of you. You have a lot of media, that is the Nelson's media, the Balamut media, the Bock and Dabolov's media. So what is all this? B, B, N, N. So what is this? So all these are definitely tough to learn. So I said that this list so I can't learn. Let me learn the other list. What is axenic? Axenic is a pure culture media, means there is no bacterial supplementation, no food. I don't need to give food. Parasite is anyway good in number, so it will grow on its own only. There is no bacterial supplementation that we have over here. So pure, and I know diamonds are pure. So what comes under the axenic media? Diamond media comes under axenic media. So please remember, diamonds are definitely very pure and shining pure. Exactly what I want all of you to know, that the diamond media is axenic pure media, and everything else, Bock, Dabolov, Nelson's, Balamut, all of those are going to be the polygenic media. Sorted? Though the culture is also done for us. What else can we see? Of course, everywhere we can do antigen antibody testing, and that is done by the very famous ELISA. I think antigen everyone knows, the Galnac lectin antigen, we already know it. One more thing. Any miscellaneous finding that you can see on a stool microscopic examination. What is that? Can you all see there's a crystal that is formed over here? Have you seen this crystal somewhere in medicine, somewhere in pathology under the asthma chapter? Socho, was there something in the asthma chapter that you read as Charcot-Leyden crystal? Yes, something that you can recall. You'll say, ma'am, what are you comparing? Asthma, lungs ka problem, matlab sputum. In sputum, I was seeing Charcot-Leyden crystal. Over here, I'm looking at a stool, diarrhea sample, and in diarrhea, you are showing me Charcot-Leyden crystal. Because tell me, guys, what was the composition of Charcot-Leyden crystal? That will tell you the entire story. It was made up of galactin 10. Galactin 10 basically comes from eosinophils. So you will realize that wherever in the entire 19 subjects, a lot of eosinophils will be there. From eosinophils, galactin 10 will come and Charcot-Leyden crystals will be seen. So can you tell me where all in the entire chapters do you see elevation of eosinophils? Either you see it in some allergy, like asthma was an allergic condition, that is why I was seeing Charcot-Leyden crystal, or you see it in parasitic infection, and Entamoeba histolytica is a parasitic infection. Simple. So either these are all miscellaneous things. You can do antigen antibody, you can do Charcot-Leyden crystals can be seen sometimes on microscopy. This is also sorted for all of us. So now you just have to go and start identifying a few pictures. Have a look at this. I'm taking a test for all of you. I've taught you everything about this. I'm taking a test. Can you tell me which is which form and how you could identify it? So first and foremost, this is the Entamoeba histolytica ka trophozoite form, and this is the cyst form. How do I identify the trophozoite? Guys, again tell me, what was the pseudopodia? This was a pointed pseudopodia that you had. How many nuclei? You had one nucleus. And what was the shape? It was a cartwheel chromatin. And can you also see one dark red spot or dark color spot? Means it has engulfed RBCs. All 3 points are there. Going on to the next, I can see this is cyst. You will say, hang on ma'am, you said cyst of Entamoeba histolytica is supposed to have 1 to 4 nuclei. Isme to 1 hai. I said 1 to 4 nuclei. So 1 is there, that's still a cyst. And look at this, it has the same cartwheel nucleus that I'm talking about. How do I know it's a cyst? Because I can also see this very thick body. What is this body? It's a chromatoid body. Chromatoid body is made up of what? What is your test? Ribonucleoprotein. Very good. If you've seen this, why don't you give me one more test? Can you identify what is this? Compare the cysts. Guys, this was the cyst right now that you told me for Entamoeba histolytica, where you said that, okay, there is cartwheel nucleus with chromatoid body. This is the cyst form of Entamoeba coli. Because in Entamoeba coli, can you see the number of the nuclei? See, I told you, it's going to have 1 to 8 nuclei. That is how you're going to differentiate it. And this is non-pathogenic. So it's very important that if you're seeing this, don't give this diagnosis to the patient unnecessarily. Entamoeba coli is non-pathogenic, so you don't have to bother much about it. But if you see this 4 nuclei wala Entamoeba histolytica, that is something you definitely have to bother about, right? Moving on further, if I ask you what is going to be the treatment, of course, you know, first you have to treat. If you see, there are 2 things. If you see trophozoite cyst, proper active disease hai, what are you going to give? For everything we give metronidazole. We are going to start off with metronidazole for 10 days. So that will treat off most of the disease. But you do believe that there are some trophozoites and amoeba which are hiding in the intestine. They are hiding in the liver. So what are you going to do? For the intestine, you're going to give a luminal amebicide, that is paromomycin. So that is why someone asks you sometimes that what if the patient is asymptomatic? What if the patient is asymptomatic and an asymptomatic carrier? He's saying, I'm not having any infection, he's not agreeing to it. He's saying, I'm not having any diarrhea, no bloody stool. Why are you giving me any treatment? You will still give him paromomycin, because if he's a carrier, this means in his lumen, the amoeba are sitting. So you will give paromomycin in that case. So remember, metronidazole with paromomycin, intraluminal amebicide is the treatment. Now guys, tell me something. Is this the only member of this family? Entamoeba histolytica and Onwer? No. Have a look at this. There's something called Entamoeba dispar, Entamoeba moshkovsky, Entamoeba bangladeshi, Entamoeba hartmanni. Let me tell you that if you look at the trophozoites of all of these, they are gonna be the same. They are the same. It's only of hartmanni. It is only of hartmanni that we are going to get a small size. The size of the organism almost, I've learned hartmanni becomes half. Okay, that is how we learn it. That hartmanni is going to become half the size. It's going to become half the size. So remember, heart for half, money for measurement. It is going to become half size or half measurement. Okay, everyone's okay with this? Otherwise, all of them look the same. So you will say, hang on again. If all of them look the same, how are you going to differentiate them? I am going to differentiate them on the basis of, number one, we can do PCR or we can do enzyme studies. There are a lot of zymodeme studies which are being done. Which can help in differentiating these. This is just a miscellaneous information that you have to know. All of them look the same. So either do a PCR for genetics or you do zymodeme analysis and differentiate them. Hartmanni I can anyway differentiate because it is half the measurement, it is half the size. That wraps up your intestinal Entamoeba histolytica and Entamoeba coli. I hope you guys are sorted with it, because now the next topic that I'm going to start off with is going to be the free living amoeba. Before we start with the free living amoeba, let's quickly scan through all the previous year one-liner wala questions that have come, and mostly for Entamoeba we've got one-liner questions. So quickly tell me, what is the diagnostic test for amoebic hepatitis? What did I teach you? That for amoebic hepatitis we'll have to look at what in the pus? We will have to look at trophozoites in the pus. If you all remember, this was the very famous anchovy sauce appearance, and this anchovy sauce appearance is going to show you trophozoites in the pus. Sorted? Let's move on to the next one-liner. What are the number of nuclei that are present in the cyst form of Entamoeba coli? So if you remember that if I compare the cyst of Entamoeba histolytica versus Entamoeba coli, Entamoeba histolytica has 1 to 4 nuclei, whereas Entamoeba coli had 1 to 8 nuclei. They asked me the mature form. The mature form will have the maximum number of nuclei. So the answer becomes 8. Let's pick up one more question from the previous years. What is the composition of the amoebic chromatoidal bars? Again, so many times I told you that mug it up thrice. Remember, I told you ratta lagao. This is made up of RNP, that is ribonucleoprotein. Let's move on to one more question. What is the most characteristic, the single characteristic feature that is most diagnostic in differentiating Entamoeba histolytica from the other intestinal amoeba like Entamoeba coli and all the others? So what is it? Is it the size alone? Size alone cannot be the only differentiating feature because many of them, remember, Entamoeba histolytica with all the others had same size. Okay. Is it the presence of chromatoidal bodies? Now tell me, chromatoidal bodies were there in Entamoeba histolytica and Entamoeba coli. So presence alone cannot differentiate. Number of the nuclei. Again, asking you one question that if, for example, you are trying to differentiate the trophozoite versus trophozoite, both of them have 1 nucleus. Even if you're trying to test the cyst versus cyst, this will have 1 to 4 Entamoeba histolytica, this will have 1 to 8, that is Entamoeba coli. But there's a variation. Both of them can show you 2, both of them can show you 4, 4. So number again is not differentiating. What is the most differentiating point is the structure of the nucleus, because if you guys remember carefully, Entamoeba histolytica had that cartwheel shape wala nucleus, right? Whereas Entamoeba coli, where was the karyosome? The karyosome was eccentric. So that is what I was telling you again and again. Entamoeba histolytica and that cartwheel nucleus is the most important point in differentiating histolytica from all the others. So option B. Right? These are all your previous year questions that you had. Now we are going to go ahead and start with the next topic, and that is the free living amoeba, and then we'll also do the ciliated organisms. That's the next family. So when I talk about free living amoeba, we have Naegleria fowleri, Acanthamoeba and Balamutia, which are the most important ones. So let's start. I'm going to actually first show you the life cycle of these two, Naegleria and Acanthamoeba. This is the life cycle of Naegleria fowleri that we have. Like every other organism, this also has a cyst and this also has a trophozoite. But if you look carefully, I've written cyst over here, but in trophozoite, I've not written trophozoite. I have written flagellaform because I want to tell you that cyst to cyst ki tarah dikhta hai, like a round cyst everywhere it has. But the trophozoite that we have, that is known as the amoeboflagella. Trophozoite is also known as amoeboflagella, which basically means that when it wants, it will have a flagella, right? It is the, many people don't know that this is the only free living amoeba that can be flagellated at times. So when it wants, it will have a flagella, and when it will, see, you can see the flagella coming out from here. When it wants, it will have a flagella, and when it doesn't want, it will start going into an amoeboid form. So iska matlab mood swings hota hai. Sometimes it is an amoeboid form and sometimes it's going to be a flagellate form. So that is why we call it the amoeboflagella. Everyone's understood? Naegleria fowleri kuch foul play kar raha hai. What foul play is it doing? It is becoming little smart that despite being a free living amoeba, Naegleria fowleri is trying to show me a foul play. That is, it's trying to show me F for fowleri, F for flagella can be there. Now moving on to the next, how does it come to us? So I can see over here that only this fowleri is actually playing a foul play. Only the flagellate form, the amoeboflagella is coming to me. The cyst is not coming to me. So if I ask you, what is the infective form over here? The infective form is just what is playing the foul play. So now you understand why I was saying foul play, because that is foul, sometimes flagellate, sometimes not. That is only fouls. It is coming into my body. So that is going to be the trophozoite form, or in other words, I will call it the amoeboflagellae form. Fine. How does it come into the body? Free living. It was free living in the environment. So this is going to come via, you can see the person is inside water if you look carefully over here. This is going to come via swimming. Basically, they will say that either the person has gone to his village or he's gone to a pond or some recreational swimming. So some swimming ka history has to be there, pond, river, somewhere he'll be swimming. And obviously if he's swimming, then via the nose, the water can go in. Na? So now what will happen, that blue color water that I want to show you over here is going to go via the nose and reach the brain. How will it reach the brain? From the nose, cribriform plate. From the cribriform plate, it's going to reach the brain. So it's going to reach the brain and it's going to cause PAM. What is PAM? That is what I can tell you. The first thing about Naegleria fowleri is it causes a disease called primary amoebic meningoencephalitis. That is what I'm calling as PAM. Primary, because it's primary, coming first time. Amoebic, it's a free-living amoeba. Meningoencephalitis via the cribriform plate, it goes into the brain. So primary amoebic meningoencephalitis is what Naegleria fowleri is causing. Now moving on. There's another one which I call as acanthamoeba. Now what is acanthamoeba? If I look carefully over here, look at the word acantho. Acantho word ka kya matlab hota hai? Acantho always means spikes. So if you look at the trophozoite of this particular organism, can you see the trophozoite is showing you spikes? That is how I will identify this life cycle. Trophozoite shows you spikes and then it also has a cyst form. What is coming to the humans? I can see the cyst is also coming to the humans. I can see the trophozoite is also coming to the humans. So I have learned acanthamoeba mein all the things are coming to the humans. If someone asks you what is the infective form, you will say everything. Trophozoite also, cyst also, all is infective. How is it coming? I can see it is coming via the inhalation route also. It is coming via the ingestion route also. I can see it is coming via the eyes and the skin also. So now what is the mode? That is also all. So acanthamoeba में सब कुछ is all. The mode of route of getting the infection, it could be anything, all. It could be inhalation, it could be ingestion, it could be cutaneous. And if I ask you what are the forms coming in, again all. Trophozoite is also coming, cyst is also coming. What is it going to cause? Now that is going to cause game. What is game? That is granulomatous amoebic, either you call it encephalitis or meningoencephalitis, whatever you want to keep it. So granulomatous amoebic meningoencephalitis is going to occur by acanthamoeba, the spiky one. So spikes pen ke we play na, we run marathons, we play cricket, spikes pen ke. So spiky wala organism is very important for me to play a game. Acanthamoeba, the one that is going to have spikes, that is the one I will wear the spikes and I will play the game, that is granulomatous amoebic meningoencephalitis. And in Naegleria fowleri, please remember, fowl kya hai? Because number one fowl, it has a flagella. That is number one fowl that it has done. It has a flagella which no one else had. And there's another fowl that it was doing was. So now we've come down to two things. Naegleria fowleri causes PAM and acanthamoeba causes game. So now let's understand their risk factors. Did I tell you Naegleria fowleri was by swimming? There was some pond swimming history. You know how acanthamoeba occurs? There will be some history of immunodeficiency. They will either give you an HIV positive patient, organ transplantation patient, some immunodeficient situation will be mentioned. Then tell me, in Naegleria fowleri, what was the infective form? Only and only the flagella wala form. Only the fowl. Remember I said fowl means it has a flagella, and that foul is that the flagella wala form is infective. That is what we are doing again and again. Number one foul is that it has a flagella, and that flagella wala form is creating the foul. That is the one that is infective. So that was the trophozoite. The trophozoite had a flagella. That was creating a foul and that was infective. Okay? Trophozoite has a flagella creating a foul and that is infective. Whereas acanthamoeba was everything. The trophozoite is also infective. The cyst is also infective. Now talking about the clinical course. ध्यान से सुनो. When I say granulomatous, go back to pathology. Granuloma is what inflammation? Chronic inflammation. Na? So what do you think is going to be the clinical course of this condition? It's going to be chronic. This means Naegleria fowleri is going to be acute, and that means I will get a history of fatality within very few days. You go back to your previous year question, you will see the girl had gone to her village for swimming. Within 5 days, she succumbed to the illness and died. But jaldi is going to happen. That is the foul play that is happening over here. Na? Jaldi it is going to happen, whereas granuloma means late, chronic inflammation. How is it spreading? Again, very simple. Remember, Naegleria fowleri was swimming, going through the cribriform plate and into the brain. So this was a neural kind of a spread. Whereas acanthamoeba could occur via inhalation, it could occur via ingestion. So it's going to enter into the blood. This means it's going to have a blood route. So I don't think you have to mug up as such this table. Little bit of logic you put and you are sorted. That for Naegleria fowleri, I have the foul wala, that is the trophozoite which has a flagella, that is the foul, and that is what is going to be the infective form. How does it enter? It enters via the nose, so matlab via the neural route. From swimming it enters into the nose, via the neural route, cribriform plate, it will go to the brain, and over here it is going to cause primary amoebic meningoencephalitis. Whereas talking about the acanthamoeba has spikes, all the routes are possible, inhalation, ingestion, cutaneous, all the things are going to be infective, trophozoite as well as cyst. So when it's going everywhere in the body, it's going to travel via the blood. What does it cause? It causes granulomatous amoebic encephalitis. Granuloma is a chronic condition. Let's move forward and let's look at the rest of the table. How would you do the diagnosis? Of course, you're going to look at the CSF in both the situation. है ना? CSF तो देखना ही पड़ेगा. So CSF में, of course, we will see it's very similar to a bacterial meningitis. Primary amoebic meningoencephalitis is very, very similar to bacterial meningitis because CSF will show you lots of polymorphs, neutrophils. And of course, trophozoite, foul play कौन कर रहा था everywhere? Trophozoite is going to be doing the foul play. Acanthamoeba, I told you that this is going to go in the blood and to all the parts of the body, and all the forms are going to be seen everywhere. Sab kuch all hota hai. You will see trophozoite also, you will see cyst also. The culture of both of them is the same. Both of them are cultured on NNA. What is NNA? Firstly, you need to know the full form. NNA stands for non-nutrient agar. NNA stands for non-nutrient agar, and please note that this is actually a lawn culture. You guys have read that in culture media. This is a lawn culture in which what is laid down? This is going to be E. coli. E. coli matlab Entamoeba coli, okay, not Escherichia coli. So NNA is done with E. coli. That is the culture for both. But the gold standard always, genetics is always going to be the gold standard. Na? So what is NAAT? This much also you know by now. You have probably studied it in a lot of places. What is NAAT? Nucleic acid amplification testing. Nucleic acid amplification testing is what is being done, matlab PCR ka form na. So PCR is always going to be the gold standard. Finally, coming to the treatment. For the treatment of Naegleria fowleri, we have amphotericin B that is given. That is one thing. But for again acanthamoeba, it is because patient is immunocompromised, immunodeficient patient. So in most of the cases, we can not understand only that what exactly needs to be given. So a combination of drugs, again all sab kuch all drugs ka combination you will have to put up. You might have to combine pentamidine with azoles, with flucytosine, with sulfonamide. So you have to multiply the drugs and you have to give a combination out there. So everything is all the forms, all the routes and all the drugs have to be combined and given up over here. So have a look at finally, jab itna all kar rahe hain, have a look at the pictures of acanthamoeba. I told you the first word, acantho word, is going to have spikes. So you will have to pick up something that has spikes, and I can see over here that there are definitely these spikes that are coming up. So this must be the trophozoite form. This must be the trophozoite form which is going to have the presence of spikes. Then how does the cyst form look like? If I look very carefully, look at the wall, the outer wall especially. Can you see the outer wall is wrinkly like this? Inner may be wrinkled, may be smooth, but outer wall is wrinkly. And that is how you identify the cyst of acanthamoeba. There is a wrinkled wall, especially I'm mentioning the outer wall is wrinkled, very, very important. So I hope everyone has understood this about acanthamoeba, the spikiness and the wrinkled wall. So these two are done. There's a very close organism known as Mandrillaris, that is B. mandrillaris, Balamutia mandillaris, and if you look at it, you will say that, ma'am, this is very, very similar to acanthamoeba. It's very, very similar to acanthamoeba. So let us pick up the differences that we have. Okay, and I will correlate this with ophthal also. So hang out. Now, what was acanthamoeba causing? Granulomatous amoebic encephalitis. Balamutia also causes the same. Okay, what were the forms of acanthamoeba that you saw? You saw trophozoites and cysts. So Balamutia also shows you the same. So yahan tak to same chal raha hai, but now there must be a difference in the shape, na? Can you see the trophozoite is somewhat looking like a fish? Yes, can you vaguely, imaginary way mein, can you make a fish out of it? Yes, so the trophozoite, I've shown you, the trophozoite is basically fish shaped. The trophozoite is going to be fish shaped, and the cyst is going to be a little more smooth. The cyst is not wrinkled. The cyst is going to be a little more smooth. So ye to chalo ma'am, finally I found one difference, that patient might have, in both the conditions, patient has granulomatous amoebic meningoencephalitis, but when I look at the cyst and the trophozoite, I'll be able to differentiate. One more thing. Do you remember acanthamoeba amoeba was only occurring in immunocompromised states, whereas Balamutia can occur in both the situations, in a normal immunocompetent person also and in an immunocompromised person also. Clear? So microscopically different dikhega, clinically patient may be different dikhega. I've done one clinical difference and I've done one microscopy difference. One ophthal difference. Which of them can infect contact lenses and cause keratitis? Which one of them can do that? I hope you guys have read this. Which of them can infect the eyes? Acanthamoeba. Very, very important. So this is an ophthal correlation that I'm doing. In contact lens users, keratitis can occur and that will occur with acanthamoeba. That will not occur with Balamutia. So I can write that over here for you guys if you want. There is going to be no amoebic keratitis that I'm going to see over here. Is that okay with everyone? Sorted? Can I, quickly solve a few questions related to it so that we get more clarity on this? Let's get going. So let's pick up two questions out here. Firstly, you have a patient with contact lens who developed corneal ulcers and symptoms of conjunctivitis. Saline mount preparation of the corneal scrapings showed a double wall cyst with an irregular or a wrinkled outer wall and a smooth inner wall. Whose cyst is being defined? So first and foremost, there was a contact lens usage. Okay, in a contact lens usage, I am seeing a patient having keratitis. Acanthamoeba comes to my mind. And as soon as I say that and I see the wrinkled wall, of course I know I am dealing definitely with a case of acanthamoeba keratitis. Anyway, you look at the others, Naegleria, Entamoeba, Giardia, they are not corneal ulcer related things. Let's pick up one more previous year question for all of us. Here you have a 15-year-old girl, this is a PYQ, who has in a village, she has returned from a vacation visiting her friend in another village. She complained, so basically when they wanted to give you a village history, how do people in village usually take a bath? In some pond or some water body. So they said that she's complained of severe headache and fever, and clinically she has been diagnosed as a case of pyogenic meningitis and admitted in the hospital. Because did I tell you pyogenic? Maybe CSF was also showing you lots and lots of neutrophils. They said this is a case of pyogenic meningitis, but look at what has happened. Within 5 days, very, very quickly, some foul play has happened and she has died very, very quickly. What is the organism that you'll consider? So firstly, we have a classical history of swimming, and as I said, within 5 days she's died, to kuch to foul play hua hai, and this means this is a case of Naegleria fowleri. So that's the answer that you have over here. I hope everyone is sorted with this information. We are done with this. Free living amoeba, done. So the next organism, which is a short family that I want to wrap up now, is the ciliated organism. In fact, this is the only ciliated parasite that I would be talking about. So please listen out very carefully, and it's a beautiful story that I have to share with all of you. When I'm talking about Belantidium coli, the way you will write it, you will write B. coli, which means coli will remind you that it is cili. Coli will remind you it is cili. It is the only ciliated parasite that you have in humans. Then the B of Belantidium will remind you of a lot of bees. So if I ask you what is the size, you will say it's big. It is the largest protozoa that you have in the human intestine. It is very, very big. Which intestine is affected? Big intestine. The large intestine is affected. So simple. The B is telling me it's big in size. B is telling me it's very, very big in terms of the intestine, large intestine affected. And next you will see that what are the two forms? Everywhere, guys, the two forms shall always and always be the trophozoid form as well as the cyst form, right? So please remember, both the trophozoid and the cyst are going to be binucleated. Both the trophozoid and the cyst are binucleated. So till now, if you remember, for example, if I make you quickly do something, Entamoeba histolytica, how many nuclei in the trophozoid? 1. How many in the cyst? 1 to 4. Entamoeba coli, how many nuclei in the trophozoid? 1. How many in the cyst? 1 to 8. But when I'm saying Belantidium coli, the trophozoid and the cyst are the same. This also has 2 nuclei. This also has 2 nuclei. Let me show you pictures. Have a look at this, guys. You will see one very big nucleus over here and one very tiny dot over here. A very big nucleus over here and a very tiny dot over here. So when I'm talking about the situation that it is binucleated, when I'm saying it is binucleated, I am trying to say that there is a big nucleus, big ya fir macronucleus, and that macronucleus, did you notice the shape of that big nucleus? It was bean shape. This macronucleus over here or the big nucleus over here was basically B for B, that is bean shape. Whereas there is a small little nucleus over here which I call as the micronucleus, and that is just like a tiny dot, which you can see again. There is a micronucleus which is just looking like a dot. So simple, another BB coming up your way, that if you have a big nucleus, that is going to be B for bean shape, that is going to be B for bean shape. You can see that everywhere. Also, if you look carefully, to chota lines you will see over here, that is just indicating that this is a ciliated organism that we have. Now, are these cilia only for show off, or with the help of these cilia or kind of pseudo-flagella, can it sometimes show a motility? Yes, please remember, it can show a motility which is known as the rotatory motility can be shown. Rotatory or active motility can be seen in these patients. Other than humans, can they have any reservoir? Yes, they can have pigs as a reservoir. Extra information that I'm telling you. And for the treatment, what are you going to give? You're going to give doxycycline. So these are some extra points about Balantidium coli. It's very unlikely to be asked. But what are the main points that you will get? The mnemonic, of course. Coli reminds you of cili. It is ciliated. B for it is big in size. B for it is big intestine. And B for it is going to be binucleated, whether trophozoite or the cyst. But which is infective out of these? Infective हमेशा cyst होता है. Most of the cases the infective form is the cyst only. Before we end it, quickly solve this question. Previous year question, all are true about Balantidium coli except, is it a protozoa? Yes. Is cyst the infective stage? Of course. Is it the largest protozoan or the parasite inhabiting the large intestine of the man? सब कुछ big? Yes. Is it invading the liver? Did I talk about anything to do with the liver? No, I was only talking about big intestine, big parasite, big intestine. So this is the wrong answer. They wanted to ask you which of them is false. One more question of the previous years coming up your way. There is no change in the number of the nuclei of the cyst and the trophozoite of. I kept telling you this again and again. The cyst and the trophozoite, both of them are binucleated. What is that organism? That organism is Balantidium coli. So with that, we have wrapped up our entire discussion of the intestinal amoeba, the free-living amoeba, and the ciliated amoeba. Now we can move on to the next family, and that is the flagellates. Starting with the next topic, and those are the Heamoflagellates. So now we are coming on to the Heamoflagellae, which means that flagella is fine, but hemo word is going to come up. Means they're going to be somewhere in the blood and the tissues. And now what are the, the things that we have to cover under it? We have a lot of trypanosomas like Trypanosoma cruzi and brucei. And then we have Leishmania, the Kala Azar one, which has even got a question in the recent FMG and the NEET 2023. So yes, on that note, let's begin. When I'm talking about Trypanosoma and Leishmania, before that, I want to tell you that all of them have something called APET. I'm trying to concise everything in one table. What is APET? Please note, there are 4 forms that are known. Pehle, everyone with me revise what is APET. Amastigot, promastigot, epimastigot, and trypomastigot. So amastigot, promastigot, epimastigot, and trypomastigot. APET is going to be the forms. What do I see inside them? Firstly, I see that in many of them, यहाँ पे flagella was trying to come out but did not come out. In all the others, definitely the flagella is coming out. So I know that all of them have a flagella coming out. But जो A mastigot है, उसके अंदर I can say A for absent flagella. In A mastigot form, the flagella will not come out. In all the others, the flagella is coming out. Simple. Where is the flagella coming out from? So I realize that, okay, in all of them, I can see a nucleus. ठीक है, N for nuke. And other than that, I can notice there is something P and B that is mentioned. So I want you guys to focus on this complex of P and B. You know what is P? P refers to a parabasal body and B refers to blepharoplast. It refers to blepharoplast because you know what are they together known as? Parabasal body and blepharoplast are together known as kinetoplast, and I am somewhere realizing that it is from this that the flagella is coming out. ये जो blepharoplast and parabasal body complex है kinetoplast, from this the flagella is coming out. So now next question is kinetoplast and nucleus का relation कैसा है? Which is anterior, which is posterior? So let me tell you a trick. The flagella end is the anterior end of all these organisms. Wherever the flagella is coming out, this means this becomes anterior end, this becomes posterior end. Same way this becomes anterior end, this, I'll just label all the anterior ends for you because you know that flagella is coming out, that is the anterior end. So do you realize that kinetoplast is always ahead of the nucleus? Over here also kinetoplast is in front of the nucleus, kinetoplast is in front of the nucleus, means kinetoplast is always going to be anterior. Whereas in a trypomastigot, kinetoplast is behind the nucleus. This is the only one which has a post-nuclear kinetoplast. So now I can tell you that in this entire table, you just have to learn three things. First, everyone's learned the format: apet, amastigot, promastigot, epimastigot, trypomastigot. If I ask you which out of these does not have the flagella, so you will say A for absent flagella. A for absent flagella is what we are going to see over here. The next thing that we notice is all of them have a flagella, but where is the flagella coming out from? Flagella comes out from kinetoplast. Kinetoplast is always aage, kinetoplast is always anterior, but which of them is going to have a post-nuclear kinetoplast? The post-nuclear kinetoplast is going to be the trypomastigot. Clear till now? Now you will ask me that all of them have all of the forms. Apet is present in all leishmanias, all trypanosomas. No, that is the tough part. And to simplify that, I've given you a chota sa mnemonic. You will realize in microbiology, we have a lot of cat wala mnemonics. This is just another cat mnemonic. So, cats are very, very frisk. Na? You must have seen, or maybe many of you have cats as pet. They keep running around from here to there. So, bet you can't keep the cat on your lap. Cat is never going to sit on your lap. Cat is always going to run around. So, remember, bet I cannot keep the cat on the lap means that when I'm talking about B for Trypanosoma brucei, what are the forms that I will see? Epimastigot and trypomastigot. Okay. When I'm talking about T cruzi, cat ke liye cruzi, I will see amastigot, I will see T for trypomastigot and E for epimastigot. And when I'm talking about L for leishmania, so leishmania mein I'm going to talk about amastigot and I'm going to talk about promastigot. How simple. So now if you learn it, otherwise it's so confusing now which one has which forms in it. So remember, bet you can't keep the cat on the lap. Bet matlab it has, brucei has epi and trypomastigot. Cruzi has amastigot, trypomastigot, epimastigot. Leishmania has A and pro. So please remember, bet you can't keep the cat on the lap. And now I'll start one by one with all of them. You will realize that yes, ma'am was right. She had given us a beautiful mnemonic because this is going to help us a lot. Before I start, all of them, how are they going to, what is their life cycle going to be? Human to sab mein hoga with one insect along with it. Some bug, some insect, some fly. So some insect is going to get that infection to us. So they tend to ask you that what are the two groups? And ye bas abhi ke liye rat lo. This you will analyze when I go to the life cycle. There are two groups. Whether the insect is going to give the organism to us in the saliva, matlab insect ne bite kara and from the saliva this has come in. Or the insect has passed the organism into the feces. So if the insect passes the organism in the feces, that insect is known as the stercoraria. And in Trypanosoma cruzi, you will see that something is going to be coming out in the shit. Something is going to be coming out in the feces, okay? Whereas if the organism is passed in the saliva, that is something that you will see in these two Trypanosomas, which are nothing but the family of Trypanosoma brucei. So one of them, basically I am saying, dono mein some insects will be there. In one of them, insect will spit it out. In one of them, insect will shit it out. Simple as that, okay? If the insect spits it out, it is Trypanosoma brucei wala life cycle. If the insect shits it out, that is stercoraria, it is going to be Trypanosoma cruzi wala life cycle. And now how am I going to learn it? So Trypanosoma brucei sounds like buccal. B for brucei, B for buccal. So which is it going to be? Is it the salivaria wala or the stercoraria wala? This means insect is going to spit it out. That is buccal se matlab spit it out. Whereas Trypanosoma cruzi matlab insect is going to shit it out. Now let's start with the first one. I'm starting with the story of Trypanosoma cruzi. Before I start with the story, I want to tell you a very, very beautiful story out here which will give you a lot of fun in reading Trypanosoma cruzi. So when I'm talking about I'm not writing it right now, I'm just giving you a quick overview. Jaise you will study, you will feel it's a beautiful mnemonic. Story time actually. Trypanosoma cruzi, so I've kept a cruise over here and I've talked about a very rich American couple. Why? Because Trypanosoma cruzi and this rich American couple, matlab they are going to live the best life, the most jhakas life they are going to live. So remember, Trypanosoma cruzi causes jhakas, means Chagas disease. Trypanosoma cruzi causes Chagas disease and this is also seen in South America. This is known as South American trypanosomiasis. So ये American couple है. अब cruise में travel कर रहे हैं, they are traveling in a cruise from their home to the cruise, they won't go in a cycle, na? They will go in a big car till the cruise. So benzonidazole. Benzonidazole is going to be the drug of choice that we have. So Mercedes-Benz mein, they're going to go to the cruise, and where are they traveling? They are basically going for their honeymoon to Rome. Honeymoon mein obviously they're going for honeymoon, so I've kept it as kissing. There is a kissing bug that is going to be involved over here, which I'm going to talk about, the kissing triatomine bug. And why have I written? Such a rich couple, na? From America, they are traveling to Rome, they have Mercedes-Benz, they are traveling in a cruise, they are living the best Chagas disease, Jhakas life. So bade log, badi batein basically means everything is going to become big. Mega esophagus, mega colon, the heart will be dilated. Sab kuch aisa big hoga. That is what is Chagas disease. That is the best story that you have to explain. Trypanosoma cruzi. So now let's start with this entire thing. When I'm talking about Trypanosoma cruzi, which I'm calling as the South American trypanosomiasis. The South American, some people even call it South American sleeping sickness, but I would want to call it American trypanosomiasis because I've told you, na, it's somewhere in America. North mein bhi hota hai, to America word dhoond lena. Trypanosoma is going to be American wala, theek hai. Definitive host of course is going to be us, that is the humans, but other than that it occurs as a reservoir in many animals, armadillos, dogs, cats, pigs, bahut sare animals mein, but definitive host for all is us. How does it come to us? So that is what I told you. There is something known as the kissing bug. There is something known as the kissing bug, and that is the triatomine bug, also known as the reduvate bug. So remember, Trypanosoma cruzi ke liye triatomine reduvate bug, जो kissing on the cruise वाला story है, you will think of. Now if I take you into the life cycle, I think you already know. If I'm saying that, acha, will you see epimastigot, amastigot, क्या दिखेगा? You'll say, okay, wait, cruzi, bet the cat will not sleep on the lap. So remember, bet the cat. Cat में, ma'am, cruzi वाले में, these are the three things you will see: amastigot, trypomastigot, epimastigot. So here I can see first and foremost, I have a human being over here. Like you told us, the definitive host is human being. Then you said one T wala, Trypanosoma T mein triatomine kissing wala bug will come. So that has come. Now my next question is, this bug is going to give me which form? Another T. The infective form is trypomastigot. Simple. You know why are they called as trypanosomes? Because what is coming to us out of amastigot, promastigot, epimastigot, trypomastigot? Trypanosomes mein trypomastigot is going to come to us. So trypomastigot is going to be the infective form. So now tell me, there is a triatomine bug which is going to give us trypomastigot form. So the triatomine bug will bite us, but how is the trypomastigot coming out? Is this bug going to spit it out or shit it out? Tell me. So Trypanosoma brucei ka life cycle होता तो ब्रूसी में it would have come via the saliva, the buccal mucosa, but ये Trypanosoma cruzi का life cycle है. Cruzi का मतलब it's gonna come out of the shit, and that means if you read very carefully in this life cycle, the bug will definitely come and bite. The bug will come and bite, but ultimately how is it going to come out of the bug? It is going to come out in the feces, trypomastigot. So what happens? Bug will come and bite. Bite matlab skin break ho gaya. Now when that bug will be rubbed, because you will obviously itch na, koi bug will come and bite you, you will itch. तो उसके feces में जो भी organism होगा, that is going to enter into you. So simple way is, although the bug bites you, but over here it's not spitting it out, it's shitting it out. Now it finally comes to you. You will see that fine, the trypomastigot form has come into you. In your body, it has changed into amastigot form. From the amastigot form, again it has changed into the trypomastigot form and entered into the blood. So we realize that when it entered into the body, into the blood, it was the trypomastigot, changed into amastigot, again into trypomastigot. So this means next time when the bug will come to take the blood meal, what will it take back? It will take the trypo. So matlab it gave the trypo, it will take the trypo. And in the bug, this trypomastigot will then change into epimastigot, back into trypomastigot, and trypo will again come to us. So simple, tet-tat ka life cycle chal raha hai. Tet-tat means in the humans, trypomastigot, amastigot, trypomastigot. And in the insect, trypomastigot, emastigot, trypomastigot. Tat, tet. Tat, tet, that is the life cycle. Tat, tet, tat, tet, shitting out life cycle. Remember that. Please note that no matter, you will see so many life cycles going forward, and in the end you won't be able to revise it. तो एक चीज याद रखना, ट्राइपोमास्टिगोट फॉर्म तो you are seeing in everywhere, humans may be, insect may be, everywhere, but in where do you see amastigot and where do you see epimastigot? तो remember, insect में, from today onwards I am going to call it insect, I am going to call it insect. Insect में क्या दिखेगा? epimastigot form दिखेगा. So that is what you should never complain of. Emastigot कहाँ दिखेगा? Insect में दिखेगा. So the amastigot form is going to be seen in the adult human beings. ठीक है? Now guys, let's talk about the disease. So what all have I done in this mnemonic? I have understood the American. It is American trypanosomiasis, very good. I have understood it is Trypanosoma cruzi, excellent. I've understood the kissing bug ka story. And now I can come down to this condition, that is, it is Jhaka's life, best life, that is Chagas disease. And Chagas disease, I will tell you now the story that this is of two types, acute Chagas disease and chronic Chagas disease. So just imagine, if the bug will come and bite you here or the eyes or anywhere, that area will become a little swollen. That is known as chagoma. Chagoma, you can say, is nothing but the entry site edema. Wherever the bug is going to come and bite you, there is going to be entry site edema. Right? Other than that, so as I said, everything is going to become big. The lymph nodes are also going to become big, lymphadenopathy. The liver and the spleen can become big, that is hepatosplenomegaly. The eyes can become big, and that is known as the Romanas sign. That is known as the Romanas sign. Let me show you a picture of Romanas sign. Can you see over here this periorbital edema? Rome. Remember the cruise may they were going to Rome. So please remember, this Romanas sign is nothing but periorbital edema that you have to know. Periorbital edema. So this is very important. That's why I told you that Chagas disease, Jhaka's life, going to Rome in a cruise, that is Trypanosoma cruzi and Romanas sign is seen. This was all seen in acute Chagas disease. What is chronic Chagas disease? Again, remember the last part of the mnemonic was bade log badi baatein, which means everything is going to become big. When I ask you about the heart, it is going to cause myocarditis, but which cardiomyopathy can it cause? When the heart becomes big, dilated cardiomyopathy. Then in the GIT, it can cause megaesophagus. If you remember in pathology, you have studied a disease called achalasia cardia. That is megaesophagus, right? So achalasia cardia hoga. Other than that, it can also cause megacolon, which is very important. Rare kuch yaad karna hai. So can it go into the brain? Can it cause meningoencephalitis? Yes, it can. It can cause meningoencephalitis. So this is everything. The site becomes big, lymph nodes are big, liver and spleen are big, the periorbital edema is big, esophagus is big, colon is big, heart is big. That is why I kept the mnemonic, everything becoming big, bade log badi baatein. And almost now, I just need to tell you what, almost completing on this mnemonic. And that is that what is going to be the diagnosis and the treatment. So let's get going. When I talk about the diagnosis part of it, what will you take as the sample? You will say, ma'am, this was roaming around somewhere in the blood. So either I can take a blood sample, and blood nahi available hai, so I can take a Buffy coat sample. I hope you all remember what is Buffy coat. Buffy coat is nothing. If this is your blood sample, obviously one part of the blood is all the red blood cells. The other part of the blood is going to be all of your fluid, that is plasma. So where does your, the WBC part go? That WBC part is going to be a part in the center, and that is known as Buffy coat. Most of your organisms are seen in the Buffy coat. Malaria ho gaya, filaria ho gaya, trypan, all the blood wale organisms are very commonly seen in the Buffy coat. So the sample is going to be blood or Buffy coat. And how do I identify it? What did I teach you? The most important form, what comes into us, goes from us, the trypomastigot. So ये जो C shape organism ऐसा दिख रहा है, and I'll show you something very interesting. Be with me guys on this. You will notice that yes ma'am, you have studied that everything important over here is going to be the trypomastigot, and in this trypomastigot we can definitely see that this is going to be the nucleus. This is the kinetoplast. How did I identify this as the kinetoplast? Because the flagella is arising from here and the flagella is going out from this end. So the flagella going out from this end makes it the anterior end. And where is the kinetoplast? Behind the nucleus. And that is what I had told you, that the only place where the kinetoplast is behind the nucleus is going to be a trypomastigot. So the post-nuclear kinetoplast is what you need to know over here. So you will identify it like this. And what is the culture that you will put it through? You will put it as Novi, McNeil and Nicole medium. So you can learn it as Novi, McNeil and Nicole medium. This is triple N media. Let me tell you abhi se only. Triple N media in microbiology is number 1 used in Trypanosoma cruzi, not in Trypanosoma brucei. It is next used in Leishmania. So this is a previous year question. Where all do you study Trypanosoma? Where all do you study the NNN media? It is number 1 going to be in the Trypanosoma cruzi and the other one is going to Leishmania, not Trypanosoma brucei. Okay, this is done. Now we come down to the story of how are you going to treat it. So like I told you, Mercedes-Benz. So this means the drug of choice is going to be benzonidazole, Mercedes-Benz ki basis pe, and baki symptomatic. If you have dilated cardiomyopathy, you might need pacemakers. If you have megaesophagus, megacolon, treat as per that. So that is what I'm saying. You treat as per the disease that the person is having, but one drug of choice, especially for acute conditions, can be benzonidazole. Now finally, when my story is done, I can come back to that mnemonic and revise. A rich American couple, so rich because look at their lifestyle. So rich American couple, American trypanosomiasis. Mercedes-Benz, benzonidazole. They are traveling in a cruise, Trypanosoma cruzi. They are going all the way to Rome because it shows you Romana sign. They are obviously going to Rome for their honeymoon. So kissing bug, triatomine bug causes it. The jackass life means Chagas disease. And bade log badi batein, all the organs were becoming mega. That is the story that you have for Trypanosoma cruzi. I hope you loved the story and you will be able to remember this. Trypanosoma cruzi is done because now I'm going to go on to Trypanosoma brucei. So first tell me brucei. Bet the cat can't sit on your lap. Bet. Matlab what all forms are going to be there? Only 2 forms. Epimastigot, trypomastigot. How simple. So now you will ask me, Trypanosoma brucei to theek hai, but what condition does it cause? Whether it is Trypanosoma brucei gambians or whether it is Trypanosoma brucei rhodesians, it causes sleeping sickness. Sleeping sickness, many people ask me, what is sleeping sickness? Very simple, sleeping in the day and not sleeping in the night and then feeling fatal and comatose and dying because of it. Sleeping sickness. So that way, ma'am, half the medicos have it. Sleeping in the day and not sleeping in the night, having insomnia, but then sleeping in the daytime. That is what all of us, our life cycle is, but hum jaisa hi hai sleeping sickness. But it's of course fatal. It can result in coma, it can result in death. So one of them is known as West African sleeping sickness and one of them is East African sleeping sickness. How do I learn which is West and East? I have a very basic first class wala thing that we used to study, that the sun is going to rise in the east and sun is going to set. Set matlab game over. Sun ka game over ho gaya. So sun is going to set in the west. Repeating, it's going to rise in the east and it's going to set in the west. So please note that when I say East African sleeping sickness, to sun rise ho raha hai, Rhodesians. Whereas when I say West African sleeping sickness, to game over ho raha hai, that is Gambians, and your mnemonic is done. Repeating, sun is rising in the east, to Rhodesians in the East African ones, and game over in the west, so Gambians is going to cause West African. And what is it? Sleeping sickness, SS. So what is the vector? SS fly, CC fly. CC fly in both the situations is going to be the vector. SS sleeping sickness, CC fly for both the situations. Glossina is its actual name when it comes to all the real biology, but yeah. Now coming to the primary reservoir. So एक का humans है और एक का animals है. How will I learn it? So humans तो सबका ही होता है. Animals किसका है? So please note, the way you write, again I'm telling you a mnemonic, the way you write East African sleeping sickness. Okay, count the number of A's. East African sleeping sickness. Whereas when you write West African sleeping sickness, तो A's किस में ज़्यादा आ रहे हैं? Who is getting more and more of A's? So of course East has an A in the name also, and Africa में तो A है ही है. West doesn't have the A in its name. तो animal किसका reservoir होगा? East African का reservoir is animal. East African sleeping sickness has the A, so that is going to have the animals as reservoir. West में it is going to be human beings. Now coming to the clinical features, as I've told you, there is going to be sleeping and sickness. तो वो तो I've understood, but one of them is going to have the very important winter bottom sign. What is winter bottom sign? I've written lymphadenopathy. So there will be a patient with usually a posterior cervical lymph node. There is a patient with a posterior cervical lymph node over here, and that is referred to as the very famous winter bottom sign. Now, which of them is more dangerous? Means we'll have more parasitemia, more virulence, more resistance. So remember, rising of everyone is, when you're rising in life, people are scared of you. You are very dangerous because you're full of zeal and determination. So jo rising wala time time hota hai na, that is always gonna be more parasitemic, more virulent and more resistance. So this means that when I'm dealing with the treatment aspect of it, जो ये game over वाला है, that तो I can treat with pentamidine. But for East African one, I will be needing suramine because it is more resistant, it is more virulent, it is more parasitemic. So I'm going to require suramine for the treatment. When I come to the diagnosis, of course, think logically. You will either take the blood sample or the sleeping sample. See, CSF, because the sleeping sickness, hai na, so it's somewhere affecting the brain. So you're going to take the CSF wala sample or you're going to take the blood sample. And what are you going to analyze in them? Which form will you see again? पूरा trypanosome family का favorite form is trypomastigot. That is why I told you we called it trypanosome because trypomastigot is the most favorite one. इसका culture क्या है? Now you will say that ma'am, in the culture for Trypanosoma cruzi and for Leishmania, for Trypanosoma cruzi and for Leishmania, you told us the triple N media, but not for Trypanosoma brucei. ये जो sleeping sickness वाला है, that sleeping sickness one is not going to be here. For that, we have a different media known as the Weinmann's media. So the man is sleeping. Please remember, sleeping sickness का जो media है, that is the Weinmann media. These छोटा stories that I keep telling you here and there, because without this, you know, microbiology cannot be studied. So remember Weinmann media, which just, even if you don't learn Weinmann, at least itna याद रखो, the triple N is not over here. Triple N is not over here. Triple N is only for Trypanosoma cruzi and Leishmania, whereas the man is sleeping. That is how we will learn it. The man is sleeping. So जो sleeping sickness है, means when I'm talking about Trypanosoma brucei, that is not going to be by triple N media. That is going to be by the Weinmann media. Okay, treatment aspect we have already done, and that makes us wrap up the entire trypanosomes. But now I want to ask you one thing. Everywhere in a subtle manner I say this also affects the heart, that also affects the heart. So why don't we make one final list of all the parasites which are causing myocarditis? And how am I going to write it? All the parasites which are going to cause myocarditis. All the parasites causing it. So there are going to be parasites with a lot of T's and E's. So these are the ones which are going to cause myocarditis. So remember, abhi we have studied something called Trypanosoma cruzi, where the heart becomes big, dilated cardiomyopathy. Even Trypanosoma brucei rhodesians, because rhodesians matlab rising na, rising is more dangerous. So heart pe danger hoga. Trypanosoma brucei rhodesians, Trypanosoma cruzi, these two we studied. Also further we'll be studying toxoplasma and trichinella. In fact, trichinella is one of the most common ones causing myocarditis. So trichinella, Trypanosoma cruzi, brucei mein if you get confused, so the rising is always more dangerous, rhodesians, Toxoplasma gondii, and with E we will have Echinococcus. Echinococcus can also cause myocarditis. That is why I told you to learn myocarditis. So all the T's will come and Echinococcus will. Let's move on to the next. The last Heamoflagella that we are left with is going to be Leishmania. First tell me, bet the cat can't keep up on the lap. So lap matlab Leishmania mein what are the two forms that I will be having? Amastigot, promastigot. Please remember, out of them, promastigot is like pro. That is what is going to take the initiative and cause the disease. So promastigot is pro, that is the one that is going to be the infective form, whereas amastigot then becomes the diagnostic form. Because I know all of you, as soon as I said Leishmania na, you guys have assumed I'm talking about Leishmania donoveni. Okay, abhi ke liye I have many other Leishmania, but abhi I'll say Leishmania donoveni. And you all study that there is something called LD bodies in Leishmania donoveni that you see. So you know what is LD bodies? Who sees LD bodies? Someone with a microscope, matlab pathologist or microbiologist. That is a person who's going to look at it under the microscope. And LD bodies, when you look under the microscope, they are nothing but amastigot form. So analysis jo hum karte hain LD bodies, that is the amastigot form that we see with Leishmania donoveni. What is going to be the vector? The vector over here is going to be the sand fly. And I think this I don't need to make any mnemonic. The disease that I'm talking about in Kala Azar. So India, especially Bihar, these are the places where you see a lot of cases of Kala Azar. So now guys, tell me one thing very quickly over here. The three organisms that I have taught you right now is Trypanosoma cruzi, Then I've taught you that sleeping sickness wala Trypanosoma brucei. And now I'm teaching you the Kala Azar one, that is Leishmania. Can you quickly revise their vectors with me? एक table बना लो जल्दी से. Tell me for Trypanosoma cruzi, you said ma'am cruise में kissing, so kissing bug. Triatomine bug is how you had, triatomine reduvid bug, how you had learnt it. Trypanosoma brucei, sleeping sickness, so CC fly is how we had learnt it. And now the only one that is left is sand fly, and that is going to be in Leishmania, Kala Azar. Simple. So now talking about Leishmania means I'm only going to have two forms, amastigot form, promastigot form. So the life cycle becomes so simple. I know you will have problems in reading it, so I will quickly write it for you once again. So first and foremost, the hint in the paper will be that there will be a sandfly that will be drawn over here, and I will have a human being that will be drawn over here. So human being and sandfly, matlab Leishmania is definitely coming to my mind. And then I will see which is the infective form, who will do the disease, promastigot. So they will always mention that it is the promastigot that has gone inside, that is the infective form, promastigot. After going inside, what will it change into your body? It will form amastigot, matlab wo LD bodies banega, amastigot. And after the amastigot, I will see that this is then finally going to be taken up by the sandfly again. So sandfly will take it up, sandfly will then convert the amastigot form into promastigot form, and the promastigot form will be given back to me. So basically what I take into us, the pro form is infective and the amastigot form is gonna go away. Simple. These are the only two forms. Itna complicate karna hi nahi hai. You just have to know. I will see a sandfly and human being wala life cycle. The pro is the pro form that is going to cause infection to me, and how I'm going to do the diagnosis is going to be via the amastigot form. Now what is the disease that I'm talking about? We're talking about Kala Azar. The recent FMG exam question also this was. And Kala Azar matlab, the reason why it's called Kala is because there is a pigmentation of the skin that you can very well see over here. There is a dark, blackened, scaly kind of a skin. So Kala word actually comes from that. Apart from that, you will see, so first and foremost I'll write the word Kala because that tells me dark, ashen, pigmented skin. You will also see a protuberant abdomen because these patients come to you with hepatosplenomegaly, and let me tell you, there is massive spleen that is defined in these patients. There is massive splenomegaly that you're going to see in these patients, right? These patients have hepatosplenomegaly. Apart from that, there are symptoms of any infection. There are fever, there is weight loss, there is weakness, night sweat. So these are, common symptoms of every infection, but the two main things are the pigmentation and the protuberant abdomen. However, there is one rare variety. And what is that rare variety? If the patient is HIV positive and the patient ends up having Kala Azar, we have seen that many a times that hepatosplenomegaly is not seen. This is an atypical presentation that you can see, that if it's HIV positive patient with Kala Azar, you might not see the protuberant abdomen. Now, this is the patient of Kala Azar in front of you. Of course, with this, you will obviously want to tell me that, ma'am, diagnosis bana do, treatment kara do. Simple as that. So, how are you going to do the diagnosis over here? Please note that for the diagnosis, first question that will come to everyone's mind is sample kya lenge. So, the sample, of course, is the very, very famous spleen. This question has come a million times in the exam. There's a long list. Okay? So they ask you in terms of sensitivity, which is the best sample that you should be taking. I should be taking an aspiration from the spleen. But do you think two very common problems that I can see? Spleen, firstly, the spleen is huge at this point of time. It's a case of Kala Azar, massive splenomegaly ho rakha hai. Secondly, spleen is an extremely vascular organ. So it can be quite disturbing because it's very vascular. It can result in a lot of bleeding. So spleen hai to best, but what is the most preferred will be a bone marrow. After that, you have a lot of other samples, like for example, you have the blood. You can even do a bronchoalveolar lavage if you have an HIV positive person, because HIV positive person, I was telling you, spleen and liver are not very commonly involved. So you might get to see it in the lungs. HIV mein to disseminated infection is noted. So yeah, these are the samples, but the question, let me tell you the question beforehand. The most sensitive sample of Leishmania that you're going to get is going to be from the spleen. After you get it, or whether you got it from the spleen or the bone marrow, what will you see? You'll say, ma'am, pro-mastigot to infection kara raha tha. Diagnosis ke liye, I need amastigot form. So, if I ask you, out of these two, which is amastigot and which is pro-mastigot, so you'll say very simple. The first point of this chapter that you told us was that amastigot form is going to have absent flagella, and I do not see any flagella coming out of it. I don't see any flagella coming out. Yahan par stop ho gaya. So, this is one thing. Next, you you told us that there will be a nucleus, and then you told us there will be a chota sa dot which is a kinetoplast. That is how I will identify this is, guys, what is known as an LD body. The other form जिसमें flagella दिख रहा है, that must be the promastigot. I am not much interested in promastigot. My diagnosis does not depend on promastigot. My diagnosis depends on these LD bodies, amastigot. And you know how are we going to see them? Please remember the LD bodies. This is another previous year question. LD bodies, which I'm calling as the amastigot form, they are not just lying everywhere. They are eaten up. Remember this line very, very well. They are eaten up or engulfed by the macrophages. So examiner na is very smart. He will not write macrophages. He will write the complicated aspect of macrophages, that is reticuloendothelial cells. Reticuloendothelial cells. So he will ask you which is the parasite which goes into the reticuloendothelial cells of the system. मतलब macrophage. Macrophage मतलब वही hepatosplenomegaly वाले macrophages. So LD bodies or amastigot. So what you see over here, this one big cell over here is a macrophage, and this another big cell over here is also a macrophage. And what do you see? If I can zoom in, I've got you zoomed in pictures. You see organism na? And देखो organism has two dot, big dot, small dot, big dot, small dot. Why big dot, small dot? The big dot is going to be the nucleus and the chota wala dot will be the kinetoplast. Look over here again. The big dot is the nucleus and the chota dot is kinetoplast. Again over here, big dot is the nucleus and the chota dot is the kinetoplast. So please remember LD bodies. This is very, very important. This picture, this sentence, LD bodies is amastigot form. LD bodies is going to be seen in the macrophage. And एक reference के लिए I've got you this one. Will you call this form amastigot or promastigot? You'll say, ma'am, there's a beautiful flagella coming out. I will have to call it promastigot form. Simple for everyone. You've done the diagnosis by looking at it, but the story is not over. You're also going to do some blood tests, some miscellaneous tests. So please note, these patients can come across as pancytopenia. Tabhi to I was saying you can do bone marrow. Now correlate. There will be a patient, I'll tell you an entire history. There will be a patient who has come to you with dark skin, who's come to you with fever and all those fever wale symptoms, night sweats, weight loss, with a protuberant abdomen. Ultrasound is showing you massive splenomegaly. Apart from that, you are also seeing that this patient is, spleen to puncture kar nahi sakte. So you said that first let me do a blood test. In that blood test, you found that this patient has pancytopenia. You'll be like, okay, something is problematic in the bone marrow. So should I be going ahead and doing the bone marrow analysis? Of course, spleen I can't puncture. It's very, very bloody, vascular. So I'll go for the bone marrow. And what will I see in the bone marrow? I will start seeing that the macrophages are showing me LD bodies. That is an entire story of a patient that I've told you. Okay, so this is one thing. What other blood tests can you do? They tend to show you a lot of gamma globulins. Hyper gamma globulinemia is seen, and there are ANA tests for it. Gamma globulin matlab antibodies na, in simple words. So antibodies ke liye aldehyde and antimony test. Antibodies ke liye what we have studied is going to be the aldehyde and antimony test. That is Napier's aldehyde and Chopra's antimony test. ठीक है, scientist का नाम भी important है. तो antibodies बढ़ा है. How will I get to know? By the aldehyde test. Although nowadays we do all of ELISA and all, these are only for MCQs. Coming to the media, that I've already told you, leishmania is by the triple N media. And the last thing is definitely going to be the PCR, because you know PCR to har jagah का gold standard है ही है. There is no doubt about it. One more thing, guys, I want all of you to know, go back to your immunology chapter. In immunology chapter, I told you all the skin tests come. No one does this test now, but immuno ke liye important hai. All the skin tests come under type 4 hypersensitivity. I'll remind you. Do you remember what was the skin test for TB? Montu's test. What is the skin test for leprosy? Lepramin test. So what is the skin test for leishmania? It is the very, very famous Montenegro test. It is the very, very famous Montenegro test. So please note that the Montenegro test is gonna be a skin test, which is that all skin tests are type 4 hypersensitivity. It's a skin test for Kala Azar that we must be knowing. Right? Now coming back, you've done the full diagnosis. This patient has actively been diagnosed. So now comes the time of his treatment. So what is the drug of choice? The drug of choice is going to be LAMP, that is liposomal amphotericin B. The drug of choice is going to be liposomal amphotericin B, which is very, very important. Now, for example, you have treated this patient. You have treated this patient with liposomal amphotericin B, and after 1 to 2 years of treatment, so after the post-Kala-Azar, he comes to you with these hypopigmented nodules. You gave him liposomal amphotericin B after 1 to 2 years of treatment. He's come to you with dermal leishmaniasis. How are they identified? Hypopigmented nodules. Now what will you treat him with? You will treat him with oral miltefosine. It's an oral drug that you give. Oral miltefosine is how you're going to treat him. So simple. First you gave him liposomal amphotericin B, treat ho gaya, very good. Nahi treat hua, he can come to you 2 years later with post Kala-Azar dermal leishmaniasis, PKDL, and then you will treat him with what? You will treat him with oral miltefosine. So this is after Kala-Azar, but that is now leishmania ho gaya, Kala-Azar ho gaya. But that is giving me a little bit of worry that without all of this, can there be some leishmanias that affect the skin only? Is there something known as cutaneous leishmaniasis? Yes. And that is not Leishmania donovani, that is Leishmania tropica. So that you can very well see is causing a cutaneous problem, and that was now a recent NEET PG 2023 question. And that is, what is cutaneous leishmaniasis? That is going, you can see, there's a very reddish color border. You can describe it. I don't need to write it also, guys. You can describe it on your own. There is an erythematous border. There is an erythematous border, and in the center of that border, you can see a lot of exudate, or you can see a lot of discharge that is present, a yellowish color discharge that is present. That is known as lots of fancy names given. Firstly, we'll call it as per maybe some sites or some places. So oriental sites, oriental sore, Delhi boil, Baghdad boil, these are one names. It is also known as the Chiclero ulcer or the Aleppo button. So I have not made any mnemonic because the jitne bhi fancy naam hai, they are coming under this ulcer. Remember Chiclero ulcer, Aleppo button, and in terms of places, oriental sore, Delhi boil, Baghdad boil, all of them are by tropical. Tropical matlab tropical, subtropical countries na, to aise I have learned. All tropica is causing all these places wala thing. Baghdad, Delhi, oriental sore. So that is L tropica. What is gonna be the treatment? I think this you know from pharmacology. Sodium stibogluconate is the treatment that you have. SSG hai na. Sodium stibogluconate is gonna be the treatment for cutaneous. There's one more thing that I want to tell you. Cutaneous to pad liya. Now I want all of you to go ahead and talk about mucocutaneous leishmaniasis. Mucocutaneous leishmaniasis is caused by what? It is caused by Braziliensis. So again I have learned Brazil, B for buccal. So sirf cutaneous nahi hoga. So when you write Braziliensis, you will learn that it is definitely to do with the skin that is cutaneous. It is definitely to do with buccal also. So this causes mucocutaneous leishmaniasis, and that is also known as espundia. You can see these lesions which are present not only on the buccal mucosa, on the skin. So that is what is caused by Braziliensis. Treatment iska bhi wahi, sodium stibogluconate is the treatment. So please revise with me. What all you studied for Kala-Azar was Leishmania donovani, LD bodies. We know that. Now what I'm going to tell you is going to be the cutaneous ones. So sirf cutaneous pucha hai, to that tropical thing they have asked you, oriental as per places, Aleppo button, Delhi boil, Baghdad boil. So that is only cutaneous. Treatment sodium stibogluconate. But if they say that there is mucocutaneous, buccal and skin is caused by Leishmania Braziliensis. Treatment again the same, that is sodium stibogluconate. Last thing, I want to ask you, what is Leishmaniasis recidivans? If you read the word recidivans, it is sounding like relapsing. Matlab you gave the treatment, but there was some problem in the treatment. You gave the treatment, liposomal amphotericin B diya tha, but now it has relapsed. So nothing but a relapsing leishmaniasis. So instead of relapsing, they've called it leishmaniasis recidivans. And what will you see with it? You will see that center mein to there is clearing. Means this part of the lesion has undergone healing. But if you will see the periphery of the lesion, there are nodular parts over here. There are nodular lesions which are gonna be present. There are nodular lesions that are present around a central healing. एक और photo देखो, beautiful picture. You can very well see that there is a central healed portion, and you can see these nodular lesions that are present on the side. This is known as Leishmania recidivans, मतलब relapse होना, inadequate treatment की वजह से. On that note, we have finished all of our Heamoflagellates and we are ready to do some MCQs out here. So first one that you have to pick up is this. Trypanosoma cruzi initially penetrated through the mucosa and multiplies in a lesion called shagoma. Okay, my mnemonic is coming into my place. In the chronic stage of the disease, what are the main lesions often observed? Yeah, it's chronic. Remember in Chagas disease, we were doing that cruise life. Bade log, badi batein, all organs were becoming big. I told you that the heart will show you dilated cardiomyopathy. Then you will see mega esophagus, you will see mega colon. So, matlab heart and GIT were the two organs in the chronic condition which I was telling you were becoming bigger. And that is what you have in front of you. Picking up the next question. So many times I have taught you this question and I hope you don't get it wrong. NNN medium is used for the isolation of. Don't read anything. Tell me your answer first. NNN medium was for Trypanosoma cruzi and it was for Leishmania. Only member of this entire chapter which is not going to grow is Trypanosoma brucei, because I told you sleeping sickness. Man will be sleeping. So sleeping sickness ke liye Weinmann medium hoga, right? So yahan pe I had to pick up Trypanosoma cruzi and I had to pick up Leishmania donovini 1 and 4, and that becomes my answer. So when you get these kind of multiple options, na, think of your answer first and then start searching for it. Let's pick up one more question out here. Very simple. Romana's sign, going to Rome. Best life, Jhaka's life. Remember, Romana's sign was Jhaka's life. That was Chagas disease. Trypanosoma cruzi causing Chagas disease, showing you Romana's sign. What was Romana's sign? It was periorbital. It was periorbital edema. Very good. One last question that we are going to take up is this. In Chagas disease, which stage is found in the muscle tissue? Again asking you, Chagas disease matlab, now first you will put up, okay ma'am, in Chagas disease, I will remember my mnemonic. Bet the cat cannot sit on the lap. Bet the cat cannot sit on the lap. तो हमें basically focus करना है cruzi पे. It has amastigot, trypomastigot, एपीमास्टिगॉट. बट एपीमास्टिगॉट तो इंसेक्ट में होता है, हमारे में होता ही नहीं है. तो एपीमास्टिगॉट चला गया. नाउ माय एपीमास्टिगॉट इज गॉन. इट हैज ओनली ATNE. प्रोमास्टिगॉट तो इट डजंट हैव ओनली. So these two options are gone. My only confusion is between amastigot and trypomastigot. If you guys remember carefully, trypomastigot was the form that was coming and going, tet, tat, tet, tat. So the one that I would see in the muscle tissue will definitely be the amastigot form. Two more questions which are like one liner wale. What is CC fly? So again, CC fly matlab sleeping sickness, and I have option number 4. This was also a PYQ that we have. To bahut jaldi ho gaya. Trypanosoma brucei, CC fly, sleeping sickness. And one last question. Winter bottom sign is seen in. So first and foremost, winter bottom sign was seen in African trypanosomiasis. There is no doubt about it. But students get confused between East African or West African. So W for W. Winter bottom sign is going to be seen in West African sleeping sickness. It is seen in West African sleeping sickness. So please remember, what was winter bottom sign? Can you recall that? So I hope there is no confusion. That is what I want to sort out this last thing on. Winter bottom sign was seen in that West African, matlab posterior cervical lymph node is how we were noticing it. Posterior cervical lymph node in West African sleeping sickness. So those signs hai. I want to wrap up this table on 2 signs. West African sleeping sickness shows you the winter bottom sign, and then there was a Romana's sign. Romana's sign, which is periorbital edema, that was seen where? Going to Rome, cruise, cruzi wala. So cruzi is going to show you the Romana's sign. Okay? Don't get confused between Romana's and winter bottom. 2 very, very important signs that you have to know in this chapter. On that note, we have entirely wrapped up this chapter. Let's begin with the next chapter of parasitology, and those are the flagellates. Now, when I'm talking about flagellates, it's very interesting because I'm going to tell you about an angry uncle and a fashionable auntie. That is how the students have also started learning it, because flagellates include Giardia lamblia, who's the grand old man of the intestine, the grand old angry man of the intestine. So that is Giardia lamblia, and Trichomonas vaginalis is a very fashionable auntie who loves diamonds and strawberries, and that's the story of how we'll be learning these two. So the story shall come eventually. Let's start with our basics. Let us start with Giardia lamblia, because that is one of the most common parasitic infections in the world. So you know the importance that this carries for us, right? Apart from that, please note, this is also the most common parasite found in the stool. So if I'm a microbiologist and I'm looking at the stool, highest chances of getting a Giardia lamblia is what I would be seeing. And of course, now you would ask me, where in the intestine or what kind of a diarrhea does it cause? So it's going to be most commonly only found in the duodenum. So what was I calling it? I was calling him a grand old man of the intestine, na, Dadaji. So grand old man of the intestine matlab Dadaji, and that is why it is found in the duodenum. So remember, Dadaji, the grand old man, that is geriatric giardia, is found in the duodenum. Now you will ask me the different stages and everything associated with it. So the infective stage, of course, will always be the cyst. Till now, infective stage is going mostly of the cyst, except for that Naegleria fowleri where foul play occurred with trophozoite. Otherwise, till here it is all going by cyst. If you ask me the infective dose, come on, I'm not going to tell you that because it has a very small infective dose. Only 10 to 25 cysts are okay to cause infection. Why? Because if you remember, guys, there was the small infectivity dose ka mnemonic. Do you guys remember? Quick revision. There was a mnemonic called Chota Small. I'm not writing it again. We've done it in detail. What is C? Cryptosporidium. H for Entamoeba histolytica. H for enterohemorrhagic E. coli. S for Shigella. And Lam for Lamblia. So Giardia lamblia also has a small infectivity dose. Where is it going to go? It's going to go into the duodenum. But how did it reach the duodenum? We ended up eating it. Something going into my duodenum is always going through the mouth only, right? So it's the feco-oral route which is very, very important. So now let me show you this entire life cycle. Like I said, in the life cycle, make it a habit. First, you will pick up what? You will pick up the host, and the host over here is only human. Rest everything is happening in the environment. And I am having some contaminated food and water, which I can see over here. And what is going to be ingested by us? What is the infective form? So that is the cyst. Fine. Again, first the cyst is going to go out. Matlab there's going to be excistation. So I can see that this is one giardia that has been drawn in front of us. You will say the first point is that when I've eaten it, this cyst is now going to change into the trophozoite. So how are all these things going to attach to my duodenum? What does it have? God has given it some very, very important structures which help in attachment. How does Giardia lamblia attach to the intestine? Remember, there is something known as a sucking disc and an antigen. These are the two things that have been given by God. Repeating once again, there is a sucking, or suckling is also how some books mention, but most books mention it as sucking disc. Please remember, most books mention it as sucking disc. So sucking disc or suckling disc as well as the lectin antigen, these are the two things that the organism has attached onto the duodenum by. Now you will say that fine, there are going to be trophozoites. The trophozoites are going to now divide. So what did you take in? You took in the cyst form. What did cyst change into? The cyst has changed into the trophozoite. Trophozoite will start dividing. Fine. After that, more cysts and more trophozoites will form. That is none of my concern. My concern is after is that it has attached to the intestine. Which part of the intestine? Duodenum of the intestine. I will ask you, what is it going to cause? Duodenum matlab small intestine, na? So think logically. If I'm talking about the small intestine means it has villi. So first I'll write over here that I'm talking about the duodenum. Now duodenum, say if something goes and gets attached, if this giardia goes and gets attached onto the duodenum, you will say it will destroy these villi. What is going to happen? There is blunting of the villi that is noted. Please note, this results in blunting. Blunting matlab aisa flattening. There is blunting of the villi that are noted, and duodenum effect hua matlab what is not going to get absorbed? Iron deficiency anemia hoga. There is IDA. Iron will not get absorbed because duodenum is affected. One more thing, because the duodenum is affected, there is another deficiency that the patient lands up with, and that is disaccharidase deficiency. Disaccharidase enzyme deficiency is also noted because of duodenum. So you'll say simple, duodenum gaya, Dadaji duodenum. So duodenum gone, so deficiency hua iron ka, disaccharidase is also not going to be there. But overall I realize everything is not going to be there. Means if the intestine is getting affected, you will say ultimately, ma'am, fat, proteins, vitamins, iron, everything will stop getting absorbed. This means my patient is going to land up with a classical malabsorption. That is, what all have I told you? There could be disaccharidase deficiency, there could be iron deficiency, even later on after the duodenum, if it attacks the ileum and the jejunum, there could be vitamin B12 and folic acid deficiency also. Other than that, there could be a protein deficiency. Overall, I am saying that there is a situation of malabsorption that has occurred. Why? Because those villi have now been blunted. Blunting of the villi, flattening of the villi has happened. But go back to your medicine, go back to your pathology. What is the hallmark of malabsorption? The hallmark of malabsorption is that fat does not get absorbed. All the fat will start going out into the stool. So what is the patient going to clinically present with? The hallmark of malabsorption, that is steatorrhea. Patient doesn't come to you and say na, that I am passing stools with steatorrhea. No. Patient comes to you saying that I am having bulky, frothy, foul-smelling stools. All the FFF, bulky, frothy, foul-smelling, and difficult to flush. The patient will say that I'm trying to flush, but the stools do not get flushed, or they stick to the pot, they stick to the pan. So remember, the frothy, foul-smelling, difficult to flush wala stools tell me that there is what? Why did I say all FFF? Because that means that there is fat that is present. So many students have a confusion that Giardia lamblia leads to that bloody diarrhea, or does it lead to fatty diarrhea? So I hope all of you have heard, there's a very famous chocolate, especially you get it in USA, the Ghirardelli chocolate. So remember, Ghirardelli is reminding me of Giardia. So I'll call it Ghirardelli. Okay, so Ghirardelli is going to be Giardia, and chocolates are obviously fatty. So remember, Ghirardelli is how I have learned it. So Ghirardelli matlab fat. So that is how you will learn that Giardia mein fatty hota hai. Giardia mein there is going to be fatty stools. This is a very famous one of your Bible books, First Aid. From First Aid only this mnemonic is there, because obviously it's made in the USA, so they made a mnemonic as per their own chocolates, right? So remember, Ghirardelli, Giardia, fatty stools. Now coming back, so blood nahi hoga is what I want to tell you. So coming back, now your cycle tells me what was the infective form. It was the cyst. How did you get it? By eating. Where did it go? It went to the duodenum. Trophozoite and cyst dono bana, and then both of them are coming out in the feces. So you will realize that the stool sample that you're going to see eventually, that will have the trophozoite and the cyst. But who will survive in the environment? It is only the cyst that survives in the environment. Only the cyst that is going to survive in the environment, and that is what will eventually come back to us. Life cycle being done, let's go on to the next part, and that is the lab diagnosis. So sample kya loge? Of course ma'am, no points, no doubts about it. I will take the stool sample. Stool sample might show you the trophozoite and cyst. Stool sample might not show you the trophozoite and cyst. Abhi ke liye I am assuming stool sample, the fatty stools, they have shown me trophozoite and cyst. So of course the next question will be, how does the microscopy come across? Of course you will see one trophozoite, and now comes the story of the angry old man. So please note, these are the pictures that you have to know. What you have over here is the very famous trophozoite of Giardia lamblia, and what you have over here is the cyst form. So tell me first thing, why did you call him the grand old man of the intestine? So what are you calling him? You are calling him the grand old angry man of the intestine. Okay, so firstly, the purpose of calling him grand old, I made Dadaji. Dadaji will go to the duodenum. Okay, after that we are calling him a man. So every man has two eyes. So two eyes matlab the trophozoite has how many nuclei? The trophozoite are going to have two nuclei. Fine. And why did I call him a grand old man? Because he has a beard, but old person has less hair na, so chota thoda beard he has. And can you see? You can see a total of 4 pairs of flagella. This is 4 pairs of flagella that you see over here. 4 pairs. Remember, this is how the examiner confuses you. Either he will write 4 pairs, or he will write 4 into 2, 8 total. So remember, has he asked you the total number, or has he asked you in pairs? Read that much information carefully. And why am I calling him angry? Because you can overall see, na, it's like a convex. It's coming, so it's looking like a little angry wala face. Hai na? So it's going to have that convexity. That is why they call it what? Lots of names given to it. They say that this can look like a pear-shaped organism. This can look like a tennis racket organism. So lots and lots of names and shapes that are given, right? Okay, this was the trophozoite. So it has 2 eyes, just like a man, and it is going to have this 4 pairs of flagella. But how is it attaching? You will see in the starting, it also has to have that sucking disc. Of course, that is how it was attaching to the Dadaji, that is the duodenum. So that is how the attachment was occurring, by the sucking disc. Now let's move on to the cyst form. 1, 2, 3, 4. How many nuclei do you see over here? In the cyst, I see 1 to 4 nuclei, and I don't see any flagella. Cyst mein flagella does not come out. In cyst, the flagella is not going to come out. You can see the flagella is basically remaining inside. and that is known as the axonemes or the axostyles. When the flagella tends to stay inside, that is known as the axostyles. It's not coming outside. It is coming outside only in the trophozoite where it's looking like a man. So coming back, this is how exactly your trophozoite and cyst form is going to look like, provided you could see it in a stool sample. You say that, ma'am, I have done 3 consecutive day stool samples. I did 3 consecutive day stool samples, but I did not see the trophozoite and the cyst. But I know this is a case of Giardia lamblia, malabsorption, steatorrhea hai. What can I do now? I'll say, where is he sitting? If he's not coming out into the stools, where is the Dadaji sitting? He's sitting in the duodenum. So try to get him in the duodenum. For that, you will now need duodenal contents. How can I get contents from the duodenum? There are 2 ways. Either I do something known as a string test. String test matlab, I'm going to have a string. I can see that string over here. And I'm going to put it into the intestine, duodenum. So that is why I call it an entero test. Because before I start with this, I want all of you to recall there was another string test, or in fact, there are 2 string tests which I have taught you way back in your bacteriology also. There is a string test that you do for Vibrio cholera. There is also a string test that you do for Klebsiella pneumoniae. Klebsiella also has a string test. I am not talking about those string tests. They are totally different. What I am talking about is the string test that you do for Giardia, because the string tests over there, what we were doing were microbiology tests. This is something that I'm going to put inside the patient. You know what I'm going to do? I will have a capsule over here. And that capsule will have this string or this thread attached. What do you do with capsules? You will tell the patient, just swallow it like any other paracetamol, just swallow this capsule. Where will this capsule go? This capsule will go down into the duodenum, and the capsule is then going to dissolve. So now you will say that, imagine the string is in your hand over here, and with that string, the capsule has gone. So one end of the string is in your hand, one end of the string is in the duodenum. After some time, you're going to pull the string out. So can I say that the string is going to have the duodenal contents, and those duodenal contents I can definitely see on microscopic examination. So basically, capsule was a dhoka. Capsule was just to swallow the string. One end of the string is in your hand, one end of the string has gone in with the capsule. So the string over here is now going to get you all of the duodenal contents, and you can look at it. You can find the trophozoites over there, right? Okay, everyone's okay with this. This was one way of getting the duodenal contents. Till now, whatever you have studied, let's look at it under the microscope. Let's take a test. Can you identify which form is this? Pehle to organism, you will say, this I'll never forget. The grand old man, the grand old angry man of the intestine. The man will tell me that, of course, there are 2 nuclei, so ye wo grand old angry man hai. And apart from that, you can see some flagella, that beard also coming out. So this is definitely the trophozoite form. Whether you saw it in the stool sample or you saw it in the duodenal sample, this is the trophozoite form that you had. But you will say that, ma'am, string test par bhi nahi aaya. Stool pe bhi nahi aaya, string test pe bhi nahi aaya. What are the other things that I can do? Maybe I can get a little bit, although not very commonly done, but maybe I can go a little bit into pathology and do a duodenal biopsy. What will I see on a duodenal biopsy? So please note that Giardia lamblia, listen to this story very carefully. Giardia lamblia is not only an angry old man, he's a girta hua man, number 1. And secondly, he's a man who is falling in the lumen, means this is a luminal organism. And you can very well see over here that this is the intestine, but the organism is seen hanging in the lumen. The organism is seen hanging in the lumen. You'll say, ma'am, hang on. Right now you said the organism was supposed to look like a pear or that tennis racket, but now it's not. Because if I show you a tennis racket like this, it will look like a tennis racket. But if I turn the tennis racket like this, it will look like a sickle. So what do you see? You see sickle-shaped organisms in the lumen. You see sickle-shaped organisms that are present in the lumen. Remember, Giardia lamblia, you have to know lamblia, matlab it is going to be the luminal organism. And why did I say girta hua man? Because it is going to show you which motility. It shows you the very, very famous falling leaf motility. Very important for us to know. So firstly, Giardia is going to be the girta hua man. So girta hua man basically tells you that yes, I will see the falling leaf. Okay, so falling leaf motility of the girta hua man, and you've also seen the duodenal contents. What all can you see? For every parasite you can do antigen antibody testing, so you will do that with ELISA. And gold standard to hamesha genetics, so the gold standard shall always remain polymerase chain reaction, there is no doubt about it. The full Girta Hua story is done for us. Now I can probably show you a set of more images. They call testing time. What is this? This is the most beautiful picture that I got on the internet. You can see that very well. You have the angry old man. This is the trophozoite. Passed in the test? Yes. What is this? This you will say, and many students have a problem in identifying it, that ma'am, how will I identify this is the cyst of Giardia lamblia? Because firstly, let me tell you, thoda sa long cyst hoga. Abhi tak whatever I'm showing you is all round. This is a little long, and you will be able to see the 4 nuclei also somewhere inside it. You will be able to see the 4 nuclei, and that axostyle, the flagella are not coming out. So ye photo kahin na kahin you will have to mug up as it is, that this is the photo of Giardia lamblia, because the same picture you will see in all your grand tests. Please remember, the drug of choice can either be metronidazole, and nowadays a lot of people are showing resistance to metronidazole, and also it's a longer therapy, so you can give a single dose of tinidazole also. So metronidazole or tinidazole is what we are gonna give. The angry old man is done. Telling you a quick recap of this story that we had for the angry old man. Firstly, why are you calling him a man? Because the trophozoite has 2 nuclei. Also, this man has old man hai na, so he's having less hair, but how many flagella? 4 pairs of flagella. After that, we are calling him the grand old man, or grand old Dadaji. So he's gonna occur in the duodenum. Then what do we have next? Giardia lamblia. So he's Girta Hua man, he's falling leaf motility, and lamblia is a luminal organism. The full story has come into place, because now forget the man, and now we are going to start with the fashionable auntie whom we call as the Trichomonas vaginalis. Of course, the name is only telling me Trichomonas vaginalis. So vagina tells me that it is to do with sexually transmitted diseases and also non-gonococcal urethritis. It is to do with STDs and non-gonococcal urethritis. So what is going to be the habitat, guys? Of course, it is going to be one of the genitals only. So that could be the urethra, the vagina, the prostate. So it occurs in both males and females. Although you call it Trichomonas vaginalis, it occurs in both males and females. You treat also both the partners. In the end, I will tell you the treatment is also of the both the partners. So urethra, vagina, prostate, dono genders mein hoga. And of course, the mode of transmission, I've told you, it's a sexually transmitted disease. Now, who is the reservoir? Females. Vaginalis name was given, na? When vaginalis name was given, this means that females are the reservoirs. Infective state. So vaginalis se I understood that females mein reservoir zyada hai. Trichomonas se I will understand that whether they ask me the infective stage, how did a person get an infection, or how will the microbiologist do the diagnosis. Whatever will be asked, I will always mark trophozoite, because this has trophozoite only. The cyst form does not exist. So please remember, when I say Trichomonas, trophozoite only, and vaginalis tells me that a females mein reservoir hai. Okay? So now you've understood why I was calling it auntie, fashionable auntie. So now let me start with the story one by one. So please remember, this is an incubation period of starting from somewhere between less than 1 week to almost 1 month, 4 to 28 days. And it infects both males and females. So males mein kya hoga? Urethritis, bladder involvement, prostate involvement. Male ka genital organ sochna, and females ka genital organs, matlab you're thinking of the very famous. Now comes the fashionable auntie. The fashionable auntie loves strawberries, exotic fruit. So strawberry cervix is what you will see. I think we all know that it is also known as colpitis macularis. When you go to your gynecology, you will study. So that is going to be strawberry cervix. And what is strawberry cervix? You'll say, ma'am, there are these red dots. So that is why, you know, some gynecologists say ki jo red dots hai, this is also looking like an angry cervix, because red color is for anger, na? So it is going to be the angry looking cervix that you have. Now, do you see on top of the cervix, what is that green color leaf? Every strawberry on the top has that green color leaf, na? So that is how I've learnt it. The strawberry will remind me of the strawberry cervix, and the green color on top is gonna remind me what is the color of the discharge that these patients come with. There is a greenish discharge that the female is going to complain of. So strawberry ka to mnemonic ho gaya. Strawberry cervix hai, and green color se I have studied that there is going to be a greenish discharge. Easy. Now let's go to the rest of the diagnosis. diagnosis. Now let's pick it up. What is the sample that you'll take? You will say, ma'am, what a joke. If the patient is coming to me with a discharge, I will of course take the discharge ka sample. That is why, guys, you must have seen gynecology mein pap smear we do from the cervix, because of course the discharge is there. So I do a pap smear. What will I see microscopically? Are you going to see trophozoite and cyst? No. This is only and only trophozoite. There is only one form that I have to see. And now comes the story of why is she a fashionable auntie. So look at her hairstyle. Hairstyle dekho, she has one long ponytail and she has this fringe cut. So that is what I'm going to show you in the trophozoite of this fashionable auntie, that is Trichomonas vaginalis. This auntie, because fringe cut means the hair are coming up till here, so eyes to chup jayega. So how many nucleus? Only one nucleus is gonna have. Is gonna have only one nucleus. Point number one, single nucleus. After that, I told you na fringe cut 1, 2, 3, 4. She has 1, 2, 3, 4. 4 anterior flagella, 4 hair coming in front, and she has one long ponytail going at the back. So this means there is one posterior flagella, and that flagella has not gone straight. See, her ponytail has not gone straight. It has gone as a wavy ban ke. Matlab, that's an undulating membrane. There's one posterior flagella with an undulating membrane. So repeating, why did I call her fashionable? Because she has 4 hair in the front, 4 anterior flagella, one ponytail going all the way back, so one posterior flagella with undulating membrane, and because fringe cut say eyes get covered, so she has only one nucleus. Easy way to analyze, and this is what you'll see on a pap smear. You can very well see this is also pear shape. Giardia was also pear shaped, but you know Giardia was an old man with two eyes. Giardia ka jo pear shape tha was a man with two eyes. This is fashionable auntie. Her eyes have been covered by her fringe cut hair, so she has only one nucleus. Giardia had 2 nuclei. I'll write down all these comparisons in a while, okay? So you can see the same pear shape organism, and of course there is going to be one nucleus with 4 anterior flagella and one long posterior flagella. Coming back, what is going to be the motility? So see, so many things you've done. Abhi you've done the strawberry ka thing, you've done her hairstyle also. The story is not over. What is the motility? So T for T, it shows you mostly, lots of names are used, wobbling, rotatory, jerky, but twitching word is very famous. So it shows you T for T. Trichomonas tends to show you twitching motility, very important. What is the culture media? What all can you see? What is left in her fashionable story of she's fashionable? She's gonna have lots of makeup, fake eyelashes she will put. She will wear a lot of diamonds and all, hai na? So what is one media that I can put up in front of her? I can put up the diamond media. I can also put up something to do with the lashes, eyelashes, lash cysteine hydrolysate serum. I know it's tough to learn, but that's the best mnemonic that I could make. Then there are others like Trussell and Johnson, Feinberg, Whittington. If you can learn, if you are like a super brain, go for it. I know it's very difficult. So I've told you the most important to learn. I've told you there is something known as diamond media. I've told you there's something to do with her lashes, and that is your final story that we have for Trichomonas vaginalis. Quickly let me know. Firstly, strawberry cervix. The green color on top tells me greenish discharge. Then she has 4 anterior flagella which are hiding her eyes, so only one nucleus. One long posterior ponytail, so one posterior flagella. She's fond of diamonds, so diamond media. She's fond of lashes, so lash media. And Trichomonas has only T for T, that is going to be the trophozoite, and apart from that it has T for T, that is the twitching motility. On that note, quickly tell me that if I show you the treatment part, I told you this was present in both males and females. So the treatment that you will do with metronidazole has to be for both the partners. Very, very important. Metronidazole has to be given to both the partners. Now coming back and asking you the differences before we end. What are the differences that you studied for Giardia, Lamblia and Trichomonas? Tell me in terms of number 1, their motility. I know one is uncle, one is auntie, that is understood, but their motility is what? This was the falling leaf. Girta hua man. This was the falling leaf motility, and Trichomonas vaginalis was going to be the twitching motility that we have. Next, I asked you what was the site. So, of course, Trichomonas is to do with all the vagina, all the genitals and everything, strawberry cervix, whereas Girta hua man, grand old man was what? Dadaji. So, that was going to be there in the Dadaji means duodenum. Now, talking about the differences of their trophozoites, can you tell me? The man could have 2 eyes. So, the man had 2 nuclei, but this auntie had eyes covered with fringe cut. So, she had only 1 nucleus. And what am I talking about in terms of flagella? The grand old man had 4 pairs of, matlab have 8 flagella, 4 pairs of beard, whereas this auntie has 4 anterior flagella, 1 long ponytail at the back, so she has total of 5. This is the most important difference that you're going to do between Giardia lamblia and Trichomonas vaginalis. I think we are ready for some MCQs to analyze if we've been able to learn the story of the uncle and auntie well. So starting with the first question over here. Which of the following is said to be true about Trichomonas? Sometimes you don't know all the answers and you have to figure it out. Tell me, does it have 5 flagella at the posterior end? Did it have 5 ponytails? No. It had 4 flagella in front and it had 1 long ponytail at the back. So this is false. They've told me to look out for the true statement. Cyst form is infective. Not at all. Trichomonas T for T. Hota hi nahi hai. There is no cyst form. False. Does it have a suckling disc for attachment? Suckling disc was there for attaching to the Dadaji duodenum. Suckling disc was there in Giardia lamblia. So this is also false. By default, the only option that I have is, does it survive well in hot and cold water? Yes. And this is your previous year question. This is the true statement. Because sometimes you don't know the exact answer, you rule out the other options and come to the right answer. Okay. Now, with that, we have finished this chapter of the flagellates. And of course, I'm going to add one word to it, that is hemo. So now we are going to start off with hemoflagellae. Means the same flagellae, motility and all that is going to be there. But now we are going to talk about it in terms of hemo, means in the blood and the tissues.